Okay, start with seizures. Okay, so seizures are a disruption and abnormal electrical discharges. Okay, this usually happens in the cortex of the brain. Okay, so the outer part of the brain is the cortex. Then you have the balance part of the brain, um, the cerebellum, and then the brainstem. Okay, so this will be more of the cortical margin areas of the brain. Okay, you'll see some obvious disturbances in the motor function. Okay, usually manifested by different types of shaking and spasms. Okay, they can also have changes in sensation and their autonomic nervous system. There can be some disturbances there, which will change visual function. Their behavior can change. For example, a petite mole. Okay, so in a petite mole, they are still conscious, and sometimes they'll just have a kind of blank stare into the distance. Okay, so some of the causes could be from cerebral injury, um, brain lesions, metabolic or nutritional disorders, and other causes are idiopathic, which means they just don't really know what's going on. Under the metabolic and nutritional ones, I'll work with cases on these since a big part of what I do is functional nutrition and functional medicine. So this one is pretty neat. So what we do is we'll actually induce the seizures on purpose, and then um, do different nutritional protocols over time, and then induce the seizures again to see the level of improvement. Um, Oftentimes, these can follow bouts of electrolyte loss, dehydration, heat stroke. Um, Even wrote a pretty good article years ago about this with some of the ideas behind metabolic and nutritional disturbances and seizures. And the cool thing about this is you can also test for it. Uh, Now, the other ones are tougher to deal with, once you have a brain injury, and the ones that are unknown, so they do what they can with different medications and so forth. So you can trigger a seizure through flashing lights, or strobes. Sometimes this is done on purpose in clinics to measure things. I don't use strobes. Well, I take that back. I'll use them a little bit, but that's not my primary method. We do it through uh, inducing different vibration frequencies into the body to stimulate this, and have footage and films of these. People are standing there. You um, overstimulate them with the triggers, and they start to have their different tremors and so forth. So there's changes in membrane potential. Okay, so if you look at the way neurons fire, so one synapse to another, okay, there are a lot of ions involved, and the brain sometimes is deficient in these things, and so that's one area where improving some of the brain nutrition can actually help. Okay, sometimes the thalamus is involved, so keep in mind the thalamus is um, responsible for all incoming input. So when you look at the front part of a brain, cross section there, right, you have the thalamus. As information is coming in from the body, so left side of the person, right side of the person. All right, so whatever the sensation is, let's say on the right side, if it's tactile, it comes in ipsilateral, goes up, decussates in the brainstem, so in the pyramids, in the brainstem area, goes to the thalamus, and then goes through to the appropriate cortex part of the brain. Okay, the primary sensory part. But all this information, if it's pain and temperature, it comes in, crosses over at the level of the cords. So now we're on contralateral side. It still has to go through the thalamus to get to the appropriate part of the brain. Okay, so sometimes the thalamus is involved. Also the reticular activating system. And if these are affected, then the person can lose consciousness. Okay, so the petit mals or the staring spells, they kind of have that distant look to them. There can be myoclonal jerks up to your grand mals with severe jerking and spasm of the muscles. Okay, if you see these, one of the goals is to try to help them, try to prevent them from hitting their head or doing any kind of head damage. You know, clear things out of the way, you know, just give them room and support. Also, some may vomit or have some sort of discharge, you know, from the mouth. And so you'll want to make sure that they don't choke. So sometimes leaning them onto their side can help prevent that. Okay, dementia is really anything that can cause some sort of deterioration of the brain. And when that happens, you start to get a decline of memory, other cognitive functions, perhaps even some motor problems, you know, just whether it's your gait or walking or movements, balance, you know, things like that is off. Okay, here's an image of a healthy brain. And this is what advanced Alzheimer's brain would look like with the atrophy. So with Alzheimer's, you do have degeneration of the neurons in the temporal lobe, frontal lobe. Okay, the brain starts to atrophy. Give me 1 second here. Okay, so overall the cause still remains unknown. On the functional medicine side, we do contribute things to environmental triggers, environmental factors, different deficiencies over time, the lack of the body's ability to protect itself because of glutathione deficiencies, and other oxidative stress that can take place. Okay, so the goal with that is to try to prevent, right? So that is a tough one because you have to start when you're young. Okay, I mean, it's never too late to start turning over a new leaf and taking care of yourself, uh, really at any age, but granted, because of limitations to matter and time and the aging process, it's better to start when you're young. Okay, but that's not really something that's promoted or taught like as a culture. You know, we're more of a symptom-based culture where you really don't do anything until you have symptoms. And usually when symptoms show up, then that's when, things have been there for a while. So hopefully this next one here is a reminder of something you probably had a long time ago, or hopefully we're exposed to it. Um, this would be an ANP1 thing, right? So things start with atoms and molecules. Okay, and if you have enough atoms and molecules, they make up the organelles of the cell, right? If, if you have enough organelles, you have a cell. Put enough cells together, you have tissue. Okay, you put enough tissue together and you have an organ. Put enough organs together and you have an organ system, like the nervous system. And then if you have enough organ systems working together, you have the organism. Okay, in our case, the human, right? Because you can have animal and plant and all that, but in our case, human. So what happens is when you start looking at certain parts of the disease process, outside of trauma, okay, trauma is an exception. Um, when you hurt enough atoms and molecules, then you're going to hurt the organelles. And if you hurt enough of those, then the cell gets hurt. If you hurt enough cells, then tissue gets hurt. And if the tissue gets hurt, then the organ is hurt. And it's usually by this time where people start to exhibit signs and symptoms, which means all of this has been in the making for quite some time. And that's the unfortunate part, is the disease process is underlying and gradual. And because our bodies are a self-healing organism, um, it can take a hit and then repair itself, and then take a hit, repair itself. But each time there could be still a negative, uh, a negative gain, right? So it's that 3 steps forward, 4 steps back kind of idea. 3 steps forward. So you are making progress, but then you actually have a loss of a step. And then if you add that up over, the decades, it eventually gets to this phase here where the organ itself is hurt enough where now you're exhibiting signs and symptoms. And then also based on our culture, even if signs and symptoms show up, people still won't do anything. So as time goes by, it gets worse. And then more organ systems are hurt. And then usually by that time, then they'll go in somewhere, whether it's general practice, hospital, whatever. And by that time, it's, in a way, it's kind of too late. Okay, so that's one concept that's put on the table by, if you read different pathology literature, it's the destruction of the little things first, and eventually the big things are damaged down the road. Okay, then as we've been talking about throughout this quarter, you've got a lot of factors to throw into that complicated formula. Genetics, epigenetics, environmental factors, things that have or have not been done to you as you age into your body, such as nutritional deficiencies, sedentary lifestyle, and so on, right? Oxidative damage. So all these things, toxic, a toxic environment, things that you're consuming that could be pro-inflammatory, and the inflammatory process itself, and that's one thing pretty much all disease has is in common is an inflammatory process, which inevitably destroys tissue. Okay, so one of the um, many goals with preventative care is to try to limit or control the inflammatory process. So the brain can experience this as well. And so when you take away certain protective factors like the glutathione, um, which everybody's deficient in, and that's also very neuroprotective. And unfortunately, that's not really something that's promoted much in our culture. So people just don't know. They don't really know to do and take things that are very neuroprotective. So, but whatever the case may be, whether it's genetic factors or environmental deficiencies and so on, at some point things develop, such as Alzheimer's. Okay, and because it's a time thing, it is a risk as you increase with age. Okay, behavioral problems and forgetfulness kind of are early signs and symptoms. Depression can be there. Okay, then at some point, they get a brain scan and you can start to see what they like to call hot spots. Okay, different hot spots in the brain that are alluding to tissue death. Okay, other forms of brain injury uh, would be vascular. Okay, so strokes. Obviously, strokes will hurt neural tissue, and then once that is hurt, it's permanent. And whatever part of the brain is affected, then that person is affected. Whether it's motor or sensory. Um, Other things like memory loss, short and long-term memory, thinking ability. Okay, they're easily agitated. Okay, they can develop anxieties. Okay, difficulty thinking and abstracting certain things during problem solving. Communication can change. Okay, normally when the people that are closest to you, which is usually family, they start to pick up on this stuff because they know you best, and then they start putting that on the table. Oftentimes, it's met with resistance and denial and agitation, and just that ego and stubbornness usually kicks in, which means they just delay the inevitable, right? Delay the process of getting care. Now, not everyone's like that. Some people are serious about their health and they're on it, but you'll also find that people are just tend to be very resistant to trying to take care of themselves. And so there's a technique out there called motivational interviewing. Okay. This one, I think all healthcare providers should take this. In fact, this was started in the 1970s with the counseling community. And what they did was they kind of went back to the drawing board because they just, as a profession, they were not really having much success in helping people through counseling, psychology, psychiatry stuff, that kind of thing. And um, so their numbers just weren't very good. And so a team got together and said, okay, let's figure this out because we are here to help people. Why are we not helping people very well? And long story short, what they discovered is um, as a counseling profession, they were telling people what to do. Stop smoking, stop doing the drugs, stop your alcoholism, stop procrastinating. They'd say things like, is this alcohol problem you have destroying you and your family and your job? Yes. Well, then stop. So they had good intentions behind, telling people to change their behavior. But that was the problem that they found, is they were telling people what to do. And they realized that humans in general do not like to be told what to do. And there's a very high chance ego is going to surface because of that and kick in and basically do the opposite of what you're trying to get them to do. A very common human behavior. So what they came up with is this thing called motivational interviewing, where you empower people to make their own choice. Okay, so it's a creative way of guiding them with certain phrases and questions and things like that to get the light bulb to go on in the person so that they make their own choice. Okay, like, so I did these courses on motivational interviewing. It's very powerful. There's many layers to it. So in other words, when it's like taking motivational interviewing 101, and there's like a 201 level and a 301 and so on, right? You can keep taking as much as you want. If everyone just took even just the 101 level, like, you would be heavily armed with wonderful information and techniques as a provider to help your patients better. Okay. And it all has to do with the way that you talk to them, the way that you present things, because you're trying to avoid the defensiveness from surfacing and kicking in. Like in my clinic, for example, the way that I approach this is, once we figure out what you have. So let's say you come in, okay, and you can't move your shoulder. Okay, you have shoulder pain, you can't move it, you can't pick up your kids, you have a hard time cooking, daily activities. I mean, everything hurts. Okay. And so once we figure out what the problem is, um, the way it's presented using motivational interviewing is, all right, so we found out what's going on. So, and you lay out in front of them on a piece of paper, here's your 3 options. You can do nothing, and here's the long-term consequence of that. We can get you out of pain, and you'll be more functional, or we can fix this. And then you back off, and you let them choose. Because if you really think about it, with just about anything in life and your health, those are your only 3 choices. Do nothing, do a little bit, or do a lot of it. Okay. And then you just tell them what happens. If you do nothing, here's what's going to happen down the road. If we only do this amount of treatment, you'll get a little bit better, and you'll get out of pain, and you'll have some improved function. But if you really fix the underlying cause, here's what's going to happen down the road, and here's how long all that's going to take. And then that's it. And you back off. And then they're looking at the sheet, and you can tell that their wheels are spinning. And what ends up happening is, whether they need time to think about it or make a decision right away, what ends up happening is they feel empowered, right? And so they made their own choice, even if the choice is, I choose to do nothing. And of course I get that. And you guys are going to get that if you haven't already from some of your patients that you may already be seeing. Okay. They're just not going to change. And, and so when that happens through motivational interviewing, there's still ways to work with them to try to make some progress. So it's a wonderful technique. So the other thing to keep in mind is the worst patients ever are your friends and family. I mean, one day you all will be, 15 years of nursing experience in some of the most advanced hospitals and equipment and techniques and things you can imagine, which means you're pretty good at what you do. Okay. You help a lot of people. And then family will come up, hey, I've got this problem. And you know exactly what it is. Well, here's what you do. And they don't even listen to you. It's like, why even ask? So because you're always little Johnny and little Sally to them. That's a subconscious thing. That's why close friends and family are they make the worst patients. Okay. So if you haven't gotten that already, they'll ask you everything, meaning friends and family. Oh, you're a nurse? That means you know everything. So they put everything on the table. And then most of it you'll be able to answer and you'll know. And then you'll put the advice and they'll be like, okay. And then that's it. They won't do anything about it. Okay. And then there's motivational interviewing on how to work with friends and family. There's also motivational interviewing for employer-employees, for relationships. for healthcare providers, for counselors, doctors, nurses, like everything. It's a wonderful technique. And if you guys are interested, you could always, there's some free stuff on YouTube. You just type it in, motivational interviewing, and there's a few things that's free that you can get started with. They've got books out there, there's seminars and webinars. You can take it as far as you want. But I honestly, I would recommend at some point, watching some of those free things that they have on YouTube. Most of them are anywhere from 5 minutes to 15 minutes, and it's quite eye opening. Okay, so with family that starts to get mental issues like dementia and the different parts that come with dementia, unfortunately, they can get pretty defensive about it, and so it's tough. It's a sad case. Deep down, they know what's going on. They don't want to admit to it. It can create tension in the family and create stress, but you just do the best you can with close friends and family to talk about it. And then as a provider, there's also a way to approach it to try to improve their quality of life. Because once they lose the ability or they have decreased ability with eating and swallowing, okay, loss of bowel and bladder control. I mean, it can be embarrassing. It's sad. Okay, it's humiliating. So there's very kind and gentle ways through motivational interviewing to help them and empower them to try to go in a better direction. Okay, with Parkinson's disease, this is damage to the basal ganglia. Okay, so there's changes in dopamine and acetylcholine. Okay, so kind of in general, if you kind of use the teeter-totter example, you want the dopamine and acetylcholine to be relatively the same. Okay, what happens is dopamine starts to become deficient, so acetylcholine wins, and because of the abnormal ratios, you start to get changes in motor function. Okay, the damage to the cells in the basal ganglia are called Lewy bodies. So when you look at these under a microscope, the cells have a certain damaged look to them that they call Lewy bodies. So they have tremors, they can be resting tremors or intention tremors. They have changes in so kinesiology is the study of human movement. So kinesio is movement. So they have akinesia, or an absence of normal movement. Okay. Rigidity. So the muscles just seem really stiff. They can have this shuffle gait. Okay. So the feet kind of, it's a hard time. They have a hard time getting started. So that's a shuffle gait. They can have this loss of facial expression that they call mask stare. Okay, they're just staring at you and you're like, what the heck are you looking at? I mean, that's not what they're doing, but that's what you want to say to them. It's like, what the heck? And, they don't mean to. It's just something that's happening. So they can drool. The intention tremors means when they start to move, their body starts to shake. Resting tremor means they're shaking just sitting there without moving. Okay, don't really have any cures for this, but we do have ways to try to help them. Okay, one way is by giving them dopamine. So you're getting those dopamine levels temporarily balanced. Okay, so if you see videos or see this in real life, after they give a bunch of dopamine, a lot of their motor function goes back to normal or mostly normal. Okay, but at some point, the dopamine stuff that you gave them wears off, and then they, their ataxia, abnormal gait, resting tremors, and so forth comes back. Okay, so that's just an ongoing treatment that they can go through. Okay, you can also give them acetylcholine blockers to try to decrease the amount of those. Okay, so some of the classic presentations, they do have this stooped posture. Now, obviously not always, right? If you're in the beginning phases, everything looks pretty much normal, and there's some subtle signs and symptoms that you may pick up on. But as things get more advanced, you certainly get into the stoop posture, um, the tremors, the blank stare that they can give you, okay, the shuffle gait. So cerebral palsy is typically a lack of oxygen to the brain at childbirth or somewhere during pregnancy, childbirth, or shortly after childbirth. And um, so it leads to different neurological disorders, leads to abnormal gait. Okay, so it can be anywhere from um, where they're in a wheelchair or they walk, they can walk assisted with crutches. Um, some uh, don't, can be mild enough where they don't really need crutches, but you can tell that like they'll walk on their tippy toes, for example. Okay, their balance is usually off. I've worked with many cerebral palsy cases over the years, and they're not coming in to look for a cure. They're coming in because the kind of work that we do can help improve their quality of life. Like, for example, there was one kid we were taking care of, and his cerebral palsy was more advanced, so he was wheelchair bound, and he was even starting to have a hard time just sitting in the wheelchair. And so the trunk muscles and all that kind of stuff was starting to become very weak, and he was having a really bad posture and stooping, and so the parents decided to start doing some more rehab, and we did. I mean, we worked very hard for a long period of time, and the parents did great with homework. They started upping their um, other therapies or different therapies at other clinics that have water. So they would strap them into a vest, special type of vest that's on ropes and a pulley type system where they can get in water and move around, which is really cool. So just a lot of different forms of exercise, and there was some dramatic improvements. Okay, it didn't cure the cerebral palsy, but it did improve quality of life. Okay, so depending on the part of the brain that's hurt, you can have the monoplegia, the hemiplegia, which is, hemi is like half, so half the body is affected, diplegia, or quadriplegia. Okay, so the um, variety of types of paralysis is variable to how much oxygen deprivation they had in the different parts of the brain that were hurt. Okay, other things can be mechanical trauma can cause it, poisons, toxins can cause it. Okay, hydrocephalus or abnormal accumulation of cerebrospinal fluid in the cerebroventricular system, right? So we have different ventricles in the brain, the third ventricle, for example, and fluid starts to accumulate, and so the pressure starts to increase. And when you start squeezing on neurological structures, you can get gait instability, urinary incontinence, and dementia. Okay, the brain stem controls a lot of function in our body, right? So a lot of cranial nerves come out of the brain stem. So if fluid starts to accumulate in the different ventricles of the brain, those ventricles tend to be close to the hypothalamus and the brainstem and the pons. Okay, so the excess fluid starts to squeeze in those areas, and because of where those nerves go, um, you know, that's one reason why the incontinence and gait can be affected. Okay, here's an example. This is a pretty extreme example, uh, but an infant has the cranial bones are not fused, so the bones can actually expand. Now, once the cranial bones fuse, okay, then the skull cannot expand, which means all that pressure is now going to get focused into the brain and crush the brain, essentially. Okay, one treatment is the ventro, uh, where they put a stent between the ventricle and the peritoneal cavity, so the ventriculoperitoneal shunt, to help with the drain, to help reduce the amount of fluid in the brain. Okay, so multiple sclerosis, or MS, is demyelination. Okay, so just a quick neuro review here. You've got the different myelin along the axon, right? And the spaces are the nodes of Ranvier. And as electrical signals coming down, it does use the myelin to pass over, hit the node of Ranvier, pass over, hit the node, which actually increases the rate of electrical transmission speed down the axon. But if that is demyelinating, or that myelin is being destroyed, then that electrical signal is going to be diminished. This is a slow and progressive process. So early signs and symptoms would be usually it's like motor muscle weakness deficit stuff. Like one day you're walking up the steps, and the next day you start tripping a little bit more over the steps. But it's still subtle enough where you're like, maybe I'm just tired, or maybe I just misjudged that. People that play the piano, for example, they're doing their beautiful thing on the piano, then all of a sudden they start missing notes and chords, and they're like, okay, maybe I'm just off for today. So it usually starts out subtle things like that. You pick up a glass 100 times that day, and two or three of them you kind of drop the glass, not enough to scream super loud, oh, I'm dealing with multiple sclerosis. But as time goes by and the gradual demyelination takes place, then now it's enough to be on their radar screen. And so they go in, they're like, something's going on. Okay. I have actually ordered different brain scans with contrast to look for MS. Some people come in and they absolutely insist. I mean, they are just freaking out. I think I have MS. I need you to order that. I'm like, okay, let's just get it ordered. Okay. Other people um, don't have that approach, but you have to put those options on the table. So it could be this, this, or this. The best way to find out is let's get a brain scan. Let's figure out what's going on. Okay. And then oftentimes people think about it, then they agree, then they go in, and it's very simple. It's either positive or negative. Okay. So that's, one reason why I like studies, blood chemistry studies, imaging studies, and so on, because they reveal information. They let you know what's going on. Okay. So a here's an example of what the demyelination starts to look like as it gets more advanced. And so as time goes by, you went from walking just fine to the motor gait is off, and then sometimes you're eventually in a wheelchair. Okay, you can also start to get blurred vision, bowel and bladder loss of control. Okay, all that stuff is smooth muscle, and your nervous system functions all that. Your nervous system functions your skeletal muscle, which is voluntary, but it also controls all the involuntary parts of your body as well. And if those nerves are demyelinating, then you start to lose those visceral functions, okay, including breathing, right? Breathing even becomes difficult. So some of the end stages of multiple sclerosis is they just have a very difficult time breathing, and they're almost suffocating to death is what ends up happening. So they try to do some steroid therapy because steroids are anti-inflammatory. They can slow down some of the inflammation and degeneration process. Other things that can maybe suppress the immune system to slow down the progression of the what they think is an autoimmune disorder. Okay. Other chronic disorders of the nervous system would be spina bifida. Okay, spina bifida is a neural tube defect, um, sometimes associated with certain nutritional deficiencies during the embryological development. Okay, we have different levels of it. You have the spina bifida occulta. Okay, this is one that I deal with quite a bit because the bony parts of the spine of the vertebra are missing. And when you take away bony parts, you take away levers and fulcrums and muscle attachment and the body's ability to be stable. So there's an instability that takes place with spina bifida occulta. Um, and and because it's so there's your sacrum, right? There's L5 and L4. So this is low back, right? So they come in with low back pain, and we end up getting x-rays, and it's like, oh, look at that, you're missing certain bony parts. You have spina bifida occulta. It may or may not have been diagnosed in youth. Some people, and with me, some people are finding out for the first time. Some people already knew that. But either way, it does create mechanical low back pain and some other back problems because they're missing some parts that would have otherwise helped with stability. In other forms, you have the spinal cord itself that stays contained within the neural canal, but the dura will exit um, the area and grow outside the body. Okay, and then you have a form where the spinal cord itself actually migrates with the dura and grows outside the body. I think it was at Vanderbilt Hospital in Nashville many years ago had their first um, intrauterine spina bifida surgery. Okay, you can look that stuff up. It's well documented. There's all sorts of pictures and just amazing work that was done. But it was they found it and they decided to do an in utero spina bifida surgery. Okay, and the first one was done at Vanderbilt Hospital in Nashville. But outside of that, once the child is born, there are still ways that they can help them these days through surgeries. Okay, amyotrophic lateral sclerosis, so that's ALS, also known as ALS, also known as Lou Gehrig's disease. Lou Gehrig was a famous baseball player for the New York Yankees back in the day with like Babe Ruth and kind of all those early um, historic baseball players, 1930s and all that. But anyway, Lou Gehrig was also known for having the most consecutive baseball games played at 2,131 games played until Cal Ripken Jr. broke that record. And Cal went on to play like 2,500 and something consecutive games, which is pretty impressive. If you think about that, they play roughly, I think, 180 games or something like that in a season, and you never miss a game. Um, so that was one thing Lou Gehrig was known for. Anyway, he got to the point where he was having the ALS symptoms, and that's accompanied by weakness. And you just, if you're a professional baseball player, motor function is extremely important. So once you start to lose that, you can't compete at a high level anymore. So he ended up retiring, and he gave that famous speech that maybe at this point y'all have seen, where he comes out and says, "Today, I consider myself the luckiest man on the face of the earth." And when you look at the history of that, he did not want to give a speech, but his teammates encouraged him, and he went out there and just winged it. That was all impromptu, and it turned out to be one of the most powerful speeches from a professional athlete. So, but shortly later thereafter, he passed away from the ALS. The reason why they call it this is, first of all, you have the lateral part of the spinal cord, right? So you have your cross section of the spinal cord. You have the gray matter, which is that butterfly shaped looking stuff in the middle. And if you divide the cord in your quadrants, right, you have the left side and the right side, and the anterior aspect and the posterior aspect of the cord. So with amyotrophic lateral sclerosis, certain areas of the spinal cord start to become sclerotic. So they start to harden and degenerate, kind of fall apart. And because the lateral area of the cord has certain motor responsibilities, and since those areas are being damaged, then their motor function is lost. Okay, so weakness, atrophy, cramping, stiffness, irregular twitching of muscles, different types of tremors, and tics, as we like to say, different little tics. Okay. Also accompanied with atrophy, so the muscles start to decrease in size because you can't use them, right? If you don't use it, you lose it, and things will deteriorate over time. I've suspected these in patients in the past and will refer out for the EMG. So what they do is they put needles in the muscle, a variety of needles, and then they pass a current through the needles, and a computer measures the rate of speed at which that electricity moves through the muscles and so forth. And there's a certain normal, but once they start to see irregularities in the waves, that's associated with ALS. Okay, so no cure for it. Most people die within 5 years after diagnosis. Okay, the spinal cord injuries, this usually happens from trauma. Okay, anywhere from just being active and bad luck, like motocross, biking, snowboarding, and you fell funny, hit a tree, diving into a swimming pool, motor vehicle accidents, and so on. Okay, can be from more aggressive things such as gunshot wounds, other penetrating wounds where the cord itself gets hurt. Certainly an area I've seen and take care of, lots of people over the years come in with different cord injuries, some more advanced than others. Sometimes at first, the body is experiencing what's called spinal shock. So the spinal cord takes quite a shock, and so you could have temporary paralysis. And they don't know if it will become permanent or not, right? So it's one of those things you kind of wait and watch. I mean, they're definitely doing treatments, they're definitely intervening, and they're doing what they can. Around here, people would go to Craig Hospital, as that's a really good place for spinal cord injuries and other neurological injuries. And I mean, they do have some really cool things these days. Different robotic devices that you can wear that are very intuitive as you're walking. The electrical synapse from these robotic pieces that you wear are trying to mimic what your body would have otherwise done on its own electronically to stimulate the brain to try to wake up again, right? To stimulate the pathways that go from body to brain. Okay, so the treatments are going to vary depending on exactly what's. Oh, someone just typed in an exoskeleton. Yeah, it is a type of exoskeleton. Um, you know, and then also dry needling is becoming increasingly popular. That's something I do on my patients, but in Craig Hospital and other um, spinal cord injury and neuro injury hospitals, you're seeing a dramatic increase in dry needling. So they stick needles into different parts of the muscle, muscle spindles, Golgi tendon organs, and so forth, and hit it with electricity to keep the muscle as electrically active as possible. Of course, that pathway is communicating with the brain to try to stimulate the brain to remember this is what it's supposed to be like. So those cells and so forth in the brain aren't lost. Okay, they're either salvaged or trying to get them back. Um, we are discovering some really cool things about neuroplasticity. I think the future on that stuff is amazing. I do think, I don't know when we'll see this, but I do think way down the road, we're going to have dramatic improvements with paralysis people, right? Cord injuries, brain injuries, and so forth. So it's out there, just it's going to take time to get there, but I do think we're going to get there one day. Okay, Guillain-Barré syndrome is inflammation of the peripheral nervous system. This can be temporary or permanent. It can lead to demyelinating. So in my family, we do have a family history of Guillain-Barré. So usually once you have a family history of that stuff, you got to be really careful what you do to minimize things that can flare it off or flare it up or cause it to happen. Um, they it's still considered idiopathic, but they do also have some ideas that can trigger it or cause it, which we'll get to in a second. Some people do spontaneously recover. Some people don't. Okay, this diagram here shows a few things. Okay, and so it can be a side effect of an association with different immunizations. And because what happens is, the different additives and preservatives, like your polysorbate 80s and thimerosal and things like that, that are found in the serum, can trigger an inflammatory response powerful enough to hurt the nervous system. Okay, so that would be an example of proceed with caution if you have a family history of this stuff. It does cause paralysis. Okay, it's usually the shoulder, what's called proximal pelvic and shoulder girdle weakness would be one. So that means this area and that area, so the shoulders and the hips kind of pretty much go out first. Now, if you take away a person's shoulder and hip stuff, then you can't move your arms, your hands, your feet, your legs. You also have a very difficult time moving around. Okay, so that's kind of a classic sign and symptom. Okay, Bell's palsy. So if you take a person's face and, we're all, that's supposed to be a straight line. Hold on. Okay, our bodies are pretty much divided in half, right? The right side of our body, the left side of our body. That division is also neurological. So usually these affect one side, okay? So one side of the body. This is an area I do quite a bit of work on with people. So what we do, and I've got lots of pictures and videos of this stuff as well, that my patients will let me, record the treatments. So what happens is it's typically a temporary surfacing of a virus. Okay. Now keep in mind, viruses, the way our immune system works and the way our nervous system works with viruses, a virus can be suppressed in ganglions. Okay. So like with the cranial nerves, you have the pterygopalatine ganglion and you have the trigeminal ganglion. And those ganglions can be a resurfacing of the virus can hit you. Okay. So right here, you're seeing a ganglion. Okay. And also that's where shingles comes from, right? So when you look at your spinal cord and those nerves that come off of the spinal cord and that wrap around your ribs, right? Those intercostal nerves. Well, you have the dorsal root ganglion. Okay. And those, like, let's say this is T5, T6, and there's the ganglion there. Okay. If the herpes zoster virus resurfaces in your body, that's now known as shingles. Okay. So once you become an adult, now they call it shingles. When you're a kid, it's chickenpox. They're still from the herpes zoster family. So kid, it's chickenpox, adult, it's shingles. But what happens is the dorsal root ganglion gets irritated. And when it gets irritated enough, the immune system in that area gets suppressed. And so this virus resurfaces, pissing off the intercostal nerve, the dermatome nerve, and so it follows a rib pattern. That's why they erupt distinctly that follow the ribs. Okay, it can be one level, it can be multiple levels. It can be T5 only, T7 only, T9 only, or it could be T5 through T9, so multiple areas. It can be unilateral, so one side, or it can be bilateral, both sides. Okay, so people that get shingles, usually it's one or more of the following: mechanical irritation to the spine, irritating the dorsal root ganglion, causing the immune system in that area to be suppressed and the virus surface, causing shingles. Also, it can be accompanied by bouts of stress, lack of sleep, and poor nutrition. Okay, those are the usual suspects that come with people that are stressed out. They don't sleep well, and they don't eat very well. Okay, and so now you've got the perfect storm to become immune suppressed overall. Well, this can also happen in the face, right? So the different ganglions that operate the cranial nerves, such as the facial nerve, can become irritated. And so when that happens, you get a temporary paralysis of the face. And So the eyelid droops, the lips droop. Uh, they just, it almost looks like a wax figure is melting. Okay, everything just droops and hangs down, and you have them do their facial expressions, smile, frown, eyebrows up, that kind of thing. Lips one way, lips the other, and they just can't really do it on one side. So what I do is you take a bunch of needles and you place them in various spots on the affected side, and then we add electricity to the wires, to the needles, and we let the electricity run. And what we're doing is we're overstimulating the cranial nerve 7, which is the facial nerve, which overstimulates the ganglion, which you can almost look at it like you're vibrating, pulsing, electrically vibrating and pulsating the virus out. So you're getting it to get, you're purging it quicker, okay, so to speak. Then that's accompanied by laser. Okay, so we do laser over the different uh, dermatome or myotome patterns that are associated with the face and the neck and different parts of the brain. And so we usually get results within 2 to 3 weeks. Okay, so it's very quick. Most people, if left on their own, it might resolve in 6 to 8 weeks. Sometimes it's permanent. Sometimes it's like half permanent, which means you only get a little bit better. And I made that term up, by the way, half permanent. But what I'm alluding to is you don't fully resolve, but you're not 100% lost either. So maybe you got 50% of your function back, or 75% of your function back, or 90%, or whatever it may be, but you're still left with some sort of loss. Okay, so everybody's different with what happens with Bell's palsy. Complete recovery, partial recovery, or no recovery. Okay, but so we do the needling, the electricity, the laser, and then we hit their body really hard with immune boosting and antiviral techniques, and it works. So within 2 to 3 weeks, usually we get um, a dramatic improvement. Okay, any questions or anything over chronic disorders of neurological function? All right. Chapter 46, alterations in sensory. Okay, those slides just review some of the normal anatomy of those parts. So we'll jump into vertigo. Okay, this is a sensation, almost like, you feel like you're on a ship, just rocking at sea. So a sensation of motion with no actual movement, or a sense of actual motion taking place. So when it's an unknown cause, then they call it benign vertigo. And I actually deal with quite a bit of this with my patients. People come in like, I'm dizzy, and oftentimes by the time I get them, they've already been to the medical route, which means they've gotten the scans, the images, the MRIs, and so on. They've tried medication, they've tried this, and nothing really seems to be working much. And there's different things that can cause vertigo. It can be very serious, anywhere from brain tumors and other, brain and cranial issues, inner ear issues, to just benign. Like there's really no reason that causes it. So, or that they know causes it. I like it when people come in that have already ruled out the creepy stuff. Okay, because now I know I'm not dealing with anything serious, and then we can dive in to try to help the vestibular system improve. Okay, so the vestibular is the part of the ear that is responsible for your balance. So let's go back up to this. All right, so you have the vestibular nerve. Okay, the vestibular nerve, and that's cranial nerve 8. So it comes, well, actually, let me take that back. It's the vestibular cochlear nerve. Okay, so the nerve comes in and branches into the vestibular part, and then there's another branch that goes to the cochlear part. And the cochlear part is what's responsible for hearing, right? There's a lot of neurological input that needs to go to that particular balance center in the brain and to the inner ear. And so sometimes people are getting vertigo because of their periphery. So like the proprioceptors in their upper cervical spine, for example. Okay, so if you irritate C1 and C2, right, atlas and axis, there's a high level of proprioceptive fibers in there. So that can cause vertigo, right? So we check for symmetry in C1 and C2 and the associated muscles, right? Your suboccipital muscles and so on, okay? And influencing those and improving those can sometimes make the vertigo go away, okay? Sometimes it's loose crystals, right? So there's a technique that you can do that in the fluid that is circulating throughout. Let me get rid of some of this stuff. Okay, so some of the fluid that's circulating throughout the semicircular canals, sometimes they can get a crystal that's kind of stuck, so to speak, or circulating funny within there. And so there's some unique head motions and certain therapy things you can do to either dislodge that or get rid of it or move it back to where it's supposed to be. Okay. And then, but, you know, there's no guarantee, right? So I usually talk to people about that. I'll say, like, look, in my experience, about half the people get better within a day or a week, and the other half, like, not much seems to happen. Okay, so, but, you know, it's so miserable for them that they're willing to try anything to get better. Okay, so impaired hearing. So one clue, well, let me back up. For some people, this is gradual, which means they don't realize they're losing their hearing over time because it's so gradual. Okay, so what will happen is, and you know, you'll see this as well, as you're trying to talk to your patient or talk to the person, first of all, they always do this. Good evening, Mr. Jones. How are you? Huh? Good evening, Mr. Jones. How are you? Oh, I'm fine. What brings you in today? Huh? What brings you in today? I mean, you're clearly speaking like as normal, and your voice projection and all that, as, I mean, it's just, it's there. And the other thing you'll notice is they tend to put the good ear toward you. So almost simultaneously when they do the classic, huh? You know, which is their way of saying what, or can you repeat that? It's just a, huh? um, while they're doing that, they're also putting their good ear toward you. Okay. And so this should be a clue. Now, they may be in there for knee pain, for back pain, for whatever, some other problem, but you're picking up that there might be something wrong with their hearing. Okay. So those are two really big clues. They want you to repeat yourself, and they typically put the good ear toward you. Okay. Now, if I pick up on this, then I will start doing some hearing tests. Now, I'm not an audiologist, so I don't have the, extremely fancy soundproof booths and the computers and the headphones and all that. But there are some basic tests that you can do right then and there. Okay, one of them is the tuning fork, right? So you grab your 512 hertz tuning fork, and you can do a variety of different tests. They're called Rhine and Weber test. Okay, this assesses hearing. Okay, you can do that right then and there. I'm not sure if you guys went over that in ANP1 back when you took that and you did cranial nerves. That's usually something I go over. What we do is we hit all the cranial nerves, cranial nerve 1, cranial nerve 2, and so on, what the cranial nerve functions, and the different tests you can do to assess for the health of that cranial nerve, right? So hearing is one of them. So there's Rhine test and Weber test, the Rub test, and some other things that you can do to assess for hearing. And if I pick up on a positive finding, you may be the first person that is actually saying something to them. So, put it on the table like, hey, I know you're here for your plantar fasciitis, but I also think you have hearing loss. And you should go get that checked, by an audiologist. And then go from there. Okay. So they do tend to speak louder to you. They'll put the good ear towards you. They ask you to repeat yourself. Um, okay, there's different things that can cause hearing impairment. Okay, some of it is just simply gradual over a period of time. Um, so they may not notice it. Some of it is pretty instant and right away, like sometimes it follows acute and nasty ear infections. Okay, so the different areas for hearing, right? You want sound waves to come down the ear canal, that external auditory meatus, and the sound waves hit the tympanic membrane or the eardrum that irritate the three different ear bones or the ear ossicles, right? The malleus, the incus, and the stapes, and that's supposed to go through the oval window and into the cochlear part of the ear. And then once those sound waves get inside the cochlea, it's supposed to irritate the fluid that's in there, and which irritates the tuft of hairs, which eventually irritates the cranial nerve and goes to the auditory part of the brain. Okay, so that's kind of your general pathway. So anything in that pathway can be hurt, okay? Busted, infringed upon, whatever. Sometimes there's foreign bodies, right? So in the ear canal, I've got a scope with speculum so I can look in your ear. I even have a camera. So the camera's hooked up to a monitor. So when we're looking in your ear, you're looking as well because you're looking at the monitor with me. And it's kind of, for you, it's kind of cool, meaning for the patient, because most people have not really seen inside of their own ear. So we put the camera in and we look for different things. And sometimes it's a foreign body, whether it's like 100% occlusion from earwax or just whatever. Okay. If it's small enough or accessible enough, I've got some tools. You can go in there and pull out the foreign body. But if it's too close to the tympanic membrane or it's too occluded or whatever, I'm like, I'm not going to even attempt at this. You need to go somewhere else to get that removed. Okay, so so a foreign body can cause it. Okay, you can have abnormal bony growth. Okay, so some sort of ossification or sclerosis or bony growth that can take place, so that which would decrease the way the ear ossicles would vibrate. Okay, could be damage to the inner ear itself, so the vestibular part could be damaged. The crystals that are inside could be broken off. There could be a lot of inflammation. Trauma can cause this. There's certain side effects of medications that are considered ototoxic uh, that can cause this. Can be congenital. You know, people are just born with either missing parts or um, neurological development is impaired. Okay, so this is why I would certainly send them to a specialist, because all that stuff, I don't, that's not what I do. I can pick up on it, and I can do a few things to look for things like Ryan and Weber tests and look in your ear and stuff like that. But either way, you're getting referred out, okay? Because the hearing impairment, so many different aspects to it. So otitis media is inflammation of the middle ear. Um, this is something that I work with quite a bit, the eustachian tube, because what happens is, hold on, let me see if I got a, okay, so here's the eustachian tube. Okay, what happens is in youth, this eustachian tube is actually more horizontal. Okay, so the eustachian tube is more horizontal, and as you age into your adult body, it becomes more um, vertical. All right, so in other words, when you are in youth, because the eustachian tube is more horizontal, it can collapse easier. Okay. And when that happens, the equalization of pressure changes, which means it's harder, and pressure has to go somewhere. So sometimes it's trying to go out, which makes the eardrum bulge. And you can pick up on that through an ear exam. Or the pressure is forcing the eardrum in. Okay. And you can also pick up on that. So what we do is we actually have techniques to open up that eustachian tube. So if the eustachian tube should be open like this and it's collapsed, okay, you can kind of see it collapsed there. We can do things to open it back up, okay, and reestablish the equalization of pressure. All right, there's a variety of methods to do that, but that's um, ultimately what we do. Okay, and then once that happens, drainage starts to continue again, equalization of pressure normalizes, pain goes away, the redness goes away, right? And then you can also get your hearing back. Um, Now, sometimes that crosses a line where the inflammation has been there for too long. And um, so you might get excessive effusion and uh, the lymphatic drainage, which is the posterior auricular lymphatic system, is also all backed up, and this can create problems, like significant problems. So in the early days, day 1 and 2, it's just painful and annoying and weird. But let's say by day 7, day 10, day 15, now we're getting into some very dangerous infection territory. Okay. All right. So there's the tympanic membrane. Notice the redness that you see. This should all be kind of a pearly white look to it, but instead it's very red and irritated. All right, you can also see the change in the tympanic membrane bulge as well. Okay, this wait and see. I mean, that is part of it, but um, so we start out with different therapies and manipulations to get the equalization of pressure to normalize, and if that crosses a line, they might need antibiotics. And then as far as tubes, I mean, I do think that tubes are preventable. Um, I think that if the usual suspects in our culture is the child has ear infections, they have ear problems, and they're simply given antibiotics, and then it happens again, and then antibiotics, and then it happens again. And this is the dance for like the first 4 years of their life or whatever. And then finally they resort to tubes. Okay. Um, or whatever the age may be. You don't have to be 4, you can be 6 or 10 or 15, but whatever the case, this is the dance. And but I do think it's worth trying certain eustachian tube and inner ear therapies first, before you resort to surgery, because it has a very high effective rate in resolving the problem. So you don't need the surgeries. But those are the options: some sort of mechanical treatment, chemical treatment such as antibiotics, and or surgery. Okay, chronic otitis media. So this has been there quite a while, thus the word chronic. And with any inflammation that lasts a long time, you're going to get adhesions. Okay, you're going to get scar tissue. You're going to get excessive fluid, the presence of fluid that's just always there. And there's usually creepy things in fluid, right? Pus byproducts, you know, lymphatic drainage materials, and so on. There's just antigens in those things, and those things are hanging out. And then that brings in more inflammation and more Pac-Mans to try to destroy the antigens, which creates more pus. And it's just this, crazy cycle that continues. So they may need surgery to remove the debris. Um, okay, so interventions are hearing aids for people, or cochlear implants, depending on the part of the ear that's damaged. Okay, they may have to go through certain therapies, like so hearing and speech go together. So, they may need to visit with a speech therapist, and, just other um, professionals that can help try to bring you back to as normal of a state as possible with the way you hear, the interpretation of hearing and sound, including the way that you talk, your speech rate and rhythm and volume and tone. Okay, the eye. Okay, another pretty important sensory structure that neurologically requires the most learning. Okay, so of all the neurostructures, this is what is considered the most difficult neural pathways to learn. Okay, so the all right. So if you look at one particular eye, what happens is you have nerves that come in and cross over. So you do have some decussation, but you also have some nerves that come in and have some ipsilateral radiation to the brain. Okay, so the eye has both decussating pathways and so contralateral and ipsilateral neurological pathways. Okay, so let's draw the other side. So we can cross over or go straight back. Okay, so there's different pathways that can be damaged that can create different visual fields of disturbances. But in general, this is how we normally see. So the red nerves that they're showing here allow you to see more of the nasal side of your vision. Okay, and then on the other side, they're trying to show the gray, right, is responsible for the more temporal. Okay, and so as a result, we can see basically like this. All right, so all of this should be our normal visual field if everything is working properly. Okay, then what can happen is if you get different damages, say to the lens or the retina or the optic nerve or the optic chiasm or the optic tract or the optic radiation or the occipital lobe itself. So anywhere in those pathways, one or more can be hurt, which would affect your visual field. Okay, some of the visual impairments can be just simply you need corrective lenses. Okay, so normally what we want is for the light to be bent and hit accurately on the back of the retina. Okay, so when you draw lines, right, at some point they converge. And right at that conversion point is where it should accurately hit the retina. Okay, now in some people, that where the lines cross, it lands too far in front of the retina. It should have been there, but it landed too far in front of it. Okay, this would create nearsightedness or myopia. And then they would get a concave lens to bend the light to accurately allow that to land correctly on the back of the retina. Okay, so that's why they flip those different strength lenses in front of you until they get the right thickness, the right bend. Okay, and then that would be your prescription. Okay, farsightedness or hyperopia would be where the light, where they cross, okay, is too far back. So then they have to put convex lenses in front of your eye to move that to land correctly like it's supposed to on the retina. Okay. So in simple terms, that's just a bending light with the appropriate type of lens to allow it to hit correctly on the posterior aspect of the retina there. So I do have you're seeing here a Snellen chart. Okay, a Snellen chart. So I do have one of those. So if I suspect certain visual things, we'll start with that. Also, I do like sports physicals and other physicals for work and whatever people need. So that's part of the exam is, vision and hearing and some muscle testing and reflexes and on it goes, right? Your basic physicals. So you just hold it up and have them read. And if you detect that they're having a hard time. It's like, well, do you wear corrective lenses? No. Ever been to an eye doctor? No. Well, you can't even see what, so, and we talk about it. It's like, if you're about to do this job or this sport that, you got to be able to see. So, you can't be cleared until you reach a certain visual standard. So go see an eye doctor and let's see what they have to say. And I have had to do that in the past. And, people usually do the, they're annoyed and they just don't want to do it. And they're kind of pissed. Okay. Now others um, take it well and they're like, okay, it makes sense. I kind of thought that might happen. And, they have no problem going to get it done. Go back to your motivational interviewing. Here's your 3 choices. You do nothing, you do a little bit, or do a lot of it. It's up to you. What do you want to do? Oh, I want to do nothing. I'm not going to do anything till my other eye goes out. Okay. Then you've got, now again, these are just things you can do right there in the office, in the exam room. Snellen chart, right? You can do your cranial nerve eye exam. LR6, SO4R3. Cranial nerve 6 operates lateral rectus, cranial nerve 4 operates superior oblique, and cranial nerve 3 operates all the rest of the eye muscles. You also have cranial nerve 2 that is responsible for vision and pupil reflex. And then cranial nerve 3, which is also responsible for opposite eye reflex, pupil reflex. Okay. So all you need is a pen light and a little bit of knowledge of your neurology and stuff like that. And you'll be able to help people. You can also have people. So here's the person sitting in your exam room and you hold up a note card directly in front of them, see if they can read it. And then you have them read a sign that's far in the back corner of the office. And they have to do it rapidly. So they read something up close and then immediately see if they can read something far away, and then vice versa. What does this thing say? And then stick the card in front of their face. What does that say? So can their eye adapt to nearsighted and farsighted, right? And you don't have to be an eye doctor to do these things. You just have to have a little bit of training, understand a little bit of how it works. And then once you detect a positive finding, okay, then you refer to the appropriate person. So in my world, I do more neuromusculoskeletal, PT, sports medicine, functional medicine stuff. So if you have an eye problem, I can find it, but I can't really do much for you. So I send you to the appropriate person. Same with hearing, and on it goes, right? Hormones that are way out of range. If you suspect any, significant problems, then we're renal disease, whatever, sending you to nephrology or to hematology or whatever the case. All right. So that's kind of how this whole circle of healthcare providers, how we help each other, help the patient, just depends on what the person is dealing with. Okay, presbyopia is loss of the accommodative capacity, so the inability to see nearby objects clearly. An astigmatism caused by an irregularity in the curves of the cornea of the lens. Okay, so they produce a distorted image. They have multiple focal points instead of just that one where light bends and hits just at one spot. They get multiple, so they get distorted images. Corrective lenses can help. So the photoreceptors in the back of the eye, your rods and your cones. Okay, so color vision is done by the cones. Okay, these are all bipolar nerves. And the dark vision or night vision is by the rods. And if you're like, what the heck are you talking about? Well, let's say you're camping and it's at night and obviously there's really no light out, okay? And your eyes have adapted to the night. That would be your night vision. And then someone comes along and shines a flashlight in your face. giving you temporary spot blindness. Now, what happens is your the 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 rods are active for night vision. Okay, and when they shined that flashlight in your face, they inhibited the rods quickly and activated the cones. But because the stimulus was so fast, you get that temporary spot blindness. And you give it time, the eyes will reset and go back to your night vision. Okay, this is why they have those red headlamps, the red light or the blue light or the green light, the red light being the more popular, because the red light filters out different spectrums of the light wavelength so that when red light hits your eyes, it does not activate the cones and it keeps the rods active. So it spares your night vision. So if you ever wonder why people have red lamps, red lights while they're camping or whatever at night, that's why. Whether they know it or not, that's why. Because it's designed to salvage your night vision, keep the rods active and keep the cones more dormant. Okay. So next time someone does that to you, you can get on them. Man, I just spent all this time getting my rods active. Now you just activated my cones. What the heck? Get a red lamp. They're gonna go, oh, what are you talking about? Never mind. Maybe a bear will get you tonight. No, don't say that part. Okay, cataracts. So this is where the lens becomes cloudy, and this usually it's gradual and it's painless, but it does cause blurred vision and eventually loss of sight. Okay, so trauma can cause it, aging can cause it. Now this one, if you really want to dive in, I don't, personally speaking, I don't necessarily buy that aging just because you're old. There's all these problems that happen. Yes, I know it's a natural course of aging, but ultimately, what we like to tap into, we meaning the functional medicine, more alternative medicine, is yes, as time goes by, okay, as time goes by, if you really do nothing, such as sedentary lifestyle, nutritional deficiencies, of course things are going to fall apart. So, yes, through that respect, the longer you live, the more problems you will likely face because you are giving your body time to adapt to the deficiencies. Okay. So, that's the position that we like to start with. In other words, you can age into a healthy body, right? You can try to tap into preventative care. You don't have to let your eyes fall apart. You don't have to let your muscles fall apart, right? Yes, of course, there's going to be some things that come with the aging package because it just does. So with my patients, I show them this graph or this chart, and it kind of looks like this, right? So here's time, okay, and here's dysfunction. All right. So it's your choice to either, as time goes by, so let's call this age 20, age 40, age 80, and let's just say age 100. Okay. So the dysfunction, as you go up, you're better. As you go down the chart, you're worse. Right. So you can either do this as time goes by, right? Just kind of fall off, just rapidly decline over time. Or you can do something like this. Okay. I mean, there's limitations to matter, limitations to humans. We don't live forever. I get it. But you don't have to do this, right? You can make it gradual over time. And that just gives you a better quality of life. And the kind of the formula for that is very simple. It's basics of exercise, basics of, a good nutrition diet protocol, minimizing stress, minimizing inflammation, Okay, having like a healthy, well-rounded, balanced lifestyle. Avoiding too much alcohol, too much drugs, and too many toxins and so forth. Okay, a lot of that is within our control. Some of it is not, including the congenital factors. So trauma, for the most part, I would say is not really intended. It's not like, Keystone just opened this past weekend. So it's not like people are going to go skiing this season and go, hey, I can't wait to go skiing so I can hit a tree at 50 miles an hour. That's not what their intention is. They want to drive there safely, they want to ski safely, and they want to get home safely. That's the intention. So in other words, trauma happens mostly by accident. We're not really asking for it. It's just an unfortunate event that takes place. Okay. So outside of trauma, other things like congenital factors, metabolic disease, side effects of medication, aging, and so on can cause uh, the vision to naturally deteriorate over time. Okay, this is what the cloudiness looks like of the cataracts as the lens is getting filled. Okay, so retinopathy is any disorder that affects the retina, which is the posterior aspect of the eye. A lot of your photosensors are, including those rods and cones. You also have the macula back there and the fovea centralis, which these are high areas of visual acuity. Okay, so they can degenerate over time. And things that don't help would be hypertension, diabetes, vascular disorders, and trauma. Okay, you can get a retinal detachment. I've seen some of these. You look, take your scope, look through the eye, look in the back, and at the back of the eye, it kind of looks like this. There's this like distinct black or off spot that's not that pretty red that you're supposed to see when you look in the back of the eye. Really nothing I can do about that, but I can pick up on it if you happen to come in. But I would just say, hey, your retinal's detaching. Really nothing I can do. Go see a specialist on that. Okay, sometimes it's spontaneous. Sometimes it's from trauma. Okay, so you start to see floating spots or some early signs and symptoms, blurred vision. Okay, some people describe it as a curtain is being pulled down over the eye. If untreated, it can lead to blindness. So it's not something you want to wait on. So there's your motivational interviewing. You can do nothing, which will lead to complete blindness. You can get it fixed now, which they will either salvage what's left or even improve your vision. Or you can wait, and the longer you wait, then the chances of you getting your vision back decline over time. Your call, buddy. No, I'll just wait. I don't mind losing vision in my eye. Okay. I'm not kidding. Sometimes you get that. Now, you hope you don't get that. You hope people are like, okay, let's do something about this. But that's an example of empowering them. Just give them their options, let them choose, and then use creative ways to encourage them to choose wisely. Okay, treatment be closing the tear. So that's usually a surgical thing. All right, diabetic retinopathies. So disorder of the retina, including the vessels. And when you look in the back of the eye, that you shouldn't see all these white spots. It should all be kind of a pretty even red. Okay. So the glucose that spins out of control, usually the blood pressure, the inadequate circulation and drainage can lead to different retinopathies because of diabetes. Okay, macular degeneration. So this is a progressive loss of central vision because the macula is a part of that acute vision, so the central vision. Okay, consider the leading cause of blindness in age 55 or older. So this one, of course, I'm a big fan of. I do think that nutritional deficiencies over time, that the body and the pigmentation, meaning the human body, and the pigmentation in your eye and the photosensors and all those components, if they don't have the ingredients to repair themselves, then of course you're going to lose the tissue and the function over time. Okay. Another one is vitamin A, which is fat soluble. Okay. And a lot of people have a problem absorbing their fat soluble vitamins, A, D, E, and K. These are very, very easy tests to do. I run these quite a bit just so people can see for themselves, like, look, here's the deficiencies. It's what we suspected. You're having early signs and symptoms with these deficiencies. And so, in other words, if you know what vitamin, mineral, and the nutrients and all that go with the body, then you know what the deficiency will be. Like, for example, B12 deficiency is often associated with decreased in energy. It can also lead to bone marrow problems because the B12 stimulates the stem cells in bone marrow, and it can also lead to neurological problems, right? So vitamin D deficiency has its host of signs and symptoms. So does vitamin A. Vitamin K would be like you have a blood clotting problem, and so on, right? So vitamin C, if really bad, you can get scurvy. And we could do this dance all day long because everything that the human body needs through micro and macronutrients, if you're deficient in it, it's going to cause problems. So we can test for it. Okay. And I like the test because compliance goes up. Well, it's because you're vitamin A deficiency. So like seriously, people, they kind of don't care if you just tell them. But once you show them through laboratory results, it's a game changer. Well, I think the reason why you're having that particular pain in that shoulder is because it's probably a bone tumor. Well, if they don't have any images to prove it, like they don't care. So we go get an x-ray. It's like, look, yep, there it is. Look at those lesions that you have in bone. Now that's a game changer. Now they're likely willing to do something about it. Okay. So it's very common when you have some sort of results, whether it's laboratory results, imaging results, or whatever, compliance goes up. It's not 100%, but it does get better. Much better than just telling them, I think you have this, I think you have that. Now we know you have this or that because we got the study back. So this is the Amsler grid that used to monitor macular degeneration. Okay, so it's just an easy test, right? So you should see this in normal conditions, but this is what they will describe with the wavy grid lines, or they're broken or distorted. They may be blurry or missing patches. Okay. So, I've got one of these, and you just have them cover one eye, look right at the dot, and then just tell them, what do you see? Okay. And if they describe something like this, well, nice, pretty paper with grids and a beautiful, perfect dot in the middle, and everything is nice and symmetrical, or whatever their descriptors or modifier is for the blurry, wavy, broken grid stuff. Okay. If they tell me anything with this in this family, I will just simply put on the table, I think you're experiencing some early stages of macular degeneration. You should go get that checked. Okay, glaucoma. because people aren't smoking enough pot. Just kidding. So intraocular pressure increases over time, causing a decrease in aqueous humor. Okay, now if you go back to the eye, here's the lens. Okay, so I'm going to divide the eye like this, right at the lens. All the front part is the aqueous humor, and all the stuff posterior to the lens would be the vitreous humor. Okay. Now, this is an increase in fluid. Now, there's a little hole there in the eye called the canal of Schlemm that we use, meaning your therapy people, like what I do, and it's called prime the eye. Okay. So you can look at the eye right now like just simply a fluid filled ball where circulation is not able to happen properly unless you prime it. Okay, and so what we do is you close your eye, right? So your eyelid is now covering your eyeball, and you take your thumb or your finger and you press on the eye. Okay, and you're priming it. You press and you squeeze and you squeeze and you squeeze. Now it's gentle, right? You're not trying to eye gouge them. And you can even do this to yourself. You know, in a way, people do it all the time, right? They rub their eyes. So if you close your eyes and just take your fingers and touch your eyeballs, you should feel kind of a squishy-ish sphere, right? The eyeball is a sphere and it's firm, but there's still a little bit of play to it. There's still a little bit of squishiness to it. It shouldn't feel like a marble, all right? And so what we do is we prime it, and we're trying to decrease the pressure from the aqueous humor buildup, and we're getting it to exit that canal of Schlemm. And it does work, but here's the catch. It's temporary. So they have to do it again, and they have to do it again. So the treatment is to increase drainage of the aqueous humor, which therefore decreases interocular pressure, and is, you know, and I've been practicing quite a long time now, and meaning long enough where the people that do this, and I mean do it for real and are consistent and on it, you know, even their eye doctors say, wow, I've really never seen this before. All these years, you've actually held steady or even reversed the glaucoma. Okay. And then, of course, the people that don't do it, or, you know, they're like, yeah, I do it like once a year. Well, it's just going to degenerate over time. Is it a guarantee that priming the eye will prevent? No, but it does help. And it's very easy to do. I mean, think about that. Close your eyes, take your fingers, press on your eyes for anywhere from 30 seconds to a minute, a couple, 3 times a day. That's it. And it helps tremendously. Okay. So I think it's worth it if a person's flirting with glaucoma stuff. To now, sometimes that canal of Schlemm is blocked, and so, and you can usually tell, like I can tell as well, when you're trying to prime the eye and you're not getting the circulation that is needed. And there's the canal of Schlemm right there. Okay. And so I will write a referral report and say, take this so they can get that canal unblocked. And sometimes they can, right? Even if they have to put a stent in it, it is openable. And once we get that open, then we can get drainage going again. Okay, so early signs and symptoms is they start to lose their peripheral vision. They start to see auras and spots and halos. Okay, and it's so gradual that they, you know, they may not really notice that they're losing their peripheral vision. And there's some easy tests that you can do in office to assess for peripheral vision stuff. And one of them is the patient is sitting down looking directly at you. And what you do is you take your fingers in your hand and you go behind their head and you wiggle your fingers and bring your hand from behind their head to the front of them so that they can see it, right? So your instructions to the patient is, once you see my fingers wiggling, I want you to let me know, right? So a bird's eye view here. Here's the patient. There's their nose. There's the eyeballs. They're looking at you this way. Okay, you're sitting there. There's your eyes. Okay, and you take your hand and you're behind their head and you wiggle your fingers. Okay, and you simply move your hand this way while wiggling your fingers. And your instructions are, as soon as you see my fingers, let me know. They should see it, you know, somewhere like that, right? Whatever their normal, the normal visual field is. Okay. So at some point they should say, if your fingers are right there, oh, I see it. And that's pretty good. However, if this is their visual field, then they're not going to see it till like right there. And you're going to go, wow, my hand is way too far in front of your face for you to just now pick up on it. Okay. So, you know, as a nurse, as a PT, as general practice, you know, you don't have to be an eye specialist to do some of these tests to pick up on, you know, glaucoma, visual disturbances, hearing problems, and whatever. You don't need expensive equipment. Um, and it reveals valuable information. Okay, visual field loss. There could be lesions anywhere along the visual pathways. And the patient will usually report, you know, as they're looking at a scenery, right? They will say, well, the center part is blacked out, or maybe this area is blacked out, or maybe that area is blacked out, and so on. Okay. Usually that indicates something in the actual neural pathway as the wires are going from the eyeball back to the occipital lobe. Okay, so monocular disease of the retina or the optic nerve. Okay, now here's an example of the different areas of infarct. Okay, optic chiasm, optic nerve, optic radiation. Okay, at that point, you know, that's where the specialist would take over with, you know, either CT scans and, you know, the other tests that they'll do to pick up on that. Okay, sense of smell. This is a chemical reaction that takes place, okay, largely involved by cranial nerve 1, olfactory nerve. Okay, there's olfactory nerve there. Okay, changes to taste and smell could be as simple as you're fighting a cold, which is the rhinovirus, or some sort of sinus infection, okay, which usually there's increased mucus and other inflammatory processes that are inhibiting adequate depolarization, repolarization stuff. So there's changes in the sensation there. So it could be as simple as that, or it could be as advanced as it's tumors. Okay. Trauma can cause it. You have mechanical trauma and chemical trauma. Okay. So mechanical trauma are things like I got hit in the head, I got hit in the nose, or whatever, some sort of head or face or nose, like actual physical mechanical trauma. You know, whether it's through motor vehicle accidents or fighting or concussions, football, whatever. Okay. Then you have chemical, which are people that work in like paint factories. They do like bathroom remodeling, constantly dealing with very strong chemicals and cleaners and whatever. Just any profession or anything that is a chemical that has a very potent smell that over time can like burn out the nerves. So that would be chemical trauma. Okay, and your test is typically you have a vial or two vials, and let's say this one has coffee beans in it, and this one has lavender in it. You have them occlude one nostril, put one of the vials underneath. What do you smell? Okay, they close their eyes, all that stuff. They're like, smells like coffee. Okay, then they occlude the other nostril, and you put a different flavor or scent, and they go, I can't even smell that. Okay, so then you have a positive finding on one of the nostrils, one or both. If you do have a positive finding, then kind of go down your deductive reasoning stuff. Is it a cold? Is it an infection? Is it from trauma, mechanical or chemical, or is it something else? Okay, such as space occupying lesions, deviated septums, infringing on things, or whatever. All right, any questions on any of that? Okay. All right, let's do pain real quick. And I mean, it would be nice to take a break, but it's almost noon. Okay, we can get through one more. This one's easy. Okay. All right, so for starters, pain is I'm going to try that again. Is nociception. So that is the fancy word for pain. Okay, so we have different sensory pathways. Okay, so the first thing you have is transduction. Like a burn. So let's say you put your hand on the hot stove. Okay, then you have transmission. Meaning the pain has to pass through a wire somewhere in our body, which would be the nervous system. Okay, and then you have, so it goes to the brain. Okay, the perception or integration, so you're processing the information. Then you have your response. So motor, also known as modulation. Okay, so in general, in your cross section of the spinal cord, okay, and we're divided in half. And here's the brain. So right brain, right side of your cord, left side of the cord. All right, so you get hurt. So let's just go back to the burn. Okay, so information, so the sensory information comes in to the dorsal horn. And because it's pain, it crosses over at the level of the cord. To the spinothalamic tract. Okay, spino. Okay, this lets you know where it's coming from and where it's going. So this would be afferent. Right, so spine to thalamus, body to brain. That's up, that's sensory, that's afferent. So the down part is efferent, also known as motor. And the way that they would let you know through the neuro language is it would say brain, body, like rubro, spinal, cortico, spinal. So these are different parts in the brain, and it's going to the spine. So when you're reading these words, whenever that may be, and you recognize, wow, there's a brain part in the word and then a body part, that's letting you know it's descending pathways or motor. If it's spine brain, that lets you know it's going up. Okay, so those are just some clues to make some of the complicated language and neuro stuff a little bit easier. Okay, so one of the pain pathways is the spinothalamic tract. So it crosses over or decussates at the level of the spine, hits your anterior lateral system, and then it goes up to the thalamus, to the appropriate part of the brain, letting you know that that area is hurt. Okay, so that's part of the transmission process. Okay, so one more time, the sensory nerve, so peripheral nerve, into the dorsal horn, crosses over at the level of the cord. Okay, at the level of the cord means if it's your hand, okay, well, where do the nerves in your hand go into? Well, they go into your spinal cord, but where? In your low back, in your mid back? Well, no, in like the neck area, like the cervical area. If it's your foot, right? If you step on a tack, you know, where does that sensory information come in? Like in your middle back? Well, no, in your low back, because your low back nerves operate the foot. So that's what we mean by at the level of the cord. Okay. Then it continues through this wire system, the nervous system, up the spinal cord, and eventually to the appropriate part of the brain. Okay, and then here's some of those levels we're talking about. So let's say you get kicked in the shin. Well, L5 is going to be the area at the level of the cord that's going to help that incoming transmission. Okay, so there's L5, So that would neurologically be the area that would come in and then eventually go up to the brain. Okay, if someone punched you in the arm, let's say right there, okay, that would be the area it's going to go in and go up to the appropriate part of the brain, and so on. Okay, so this is showing the incoming information, dorsal nerve root, dorsal horn, crossing over, that's decussation, hitting the ascending areas, the ascending fibers, okay, and then sending information to the brain. Okay, your so some of the wires transmit faster than others. Okay, so we have sensory afferent neurons, and then they can synapse, which they have to, on other neurons. Okay, and then also there's a different speed at which some of these are transmitted. Okay, so we have excitatory, okay, excitatory pain fibers. Okay, the C fibers, though, happen to be slower. So in other words, slower at transmitting the impulse. Okay, and then you have the alpha fibers, which are fast. Okay, the alphas are myelinated, the C fibers are unmyelinated. Okay, the sharp, aggressive stuff will usually recruit the alphas. The chronic, dull, annoying things will recruit the C fibers. This is the one that I deal with the most. You know, if you kind of think about a PT world, oh, my low back is always hurting. Oh, my knee's always hurting. Oh, it's always aching. Always this, always that. The C fibers are just screaming like crazy. Okay. And then one thing that we try to do is when you increase proprioception, you decrease nociception. So what that means is if you can get the area moving properly, reduce some of the spasming, reduce the tension, reduce the joint dysfunction, reduce the inflammation, reduce the edema, get it moving better, you increasing proprioception. And what happens is you start to decrease nociception, you decrease the pain. Okay, so that's one reason why some of the, you know, the modalities that we do, electric stim, dry needling, certain other movements and therapies, whenever ultrasound, you know, these help. Okay, that's why people oftentimes feel better, you know, after these kind of therapy sessions. Medication tries to do it by blocking some of the pain fibers. Like, for example, NSAIDs block the COX-2s, which is part of the inflammatory process. So if you can block it, then you decrease inflammation. Okay. And there's different neurotransmitters and other, you know, cascade of events in our bodies that medication can block to help pain management for you or for the person. Okay, we also have the release of P substance. Okay, so there's different neurotransmitters that are responsible to help you interpret pain. Okay, P substance is one of those. Okay, the amino acid, an excitatory amino acid called glutamate is another one. Okay, your GABAs. Okay, so this is something that I issue to people. I do a natural version of GABAs. Medically, they will want to do gabapentin. But what they're trying to do is tap into the gamma aminobutyric acid phenomenon that your body does through an excitatory amino acid. Okay, also at some point, with pain modulation, movement is a part of that. Ever notice when you hit your, like let's say you hit your thumb with a hammer, there's two things people do automatically. Number one, profanity. Simultaneously, they shake the hand that they hit, right? So I don't know what it is. These two always go together. Some sort of language comes out when you hit your thumb with a hammer, and then they shake their hand at the same time. Now, the reason why they're shaking their hand is because they don't know this, but what they're trying to do is increase movement. And when you increase movement, which is increase the proprioceptive stuff, you decrease nociception, which means you decrease the pain transmission. Okay, so this is pain modulation, and that's one way our body does it is through movement. Another way it does it is through my pen's not working. Okay, through opioids. Okay, an example of that would be an enkephalin, and everybody has a different amount of these. So some people have a high pain tolerance, some people don't. Okay, and then once the opioids, your natural built-in opioids are released, that helps block some of the pain. Now here's what happens, and there's another thing I deal with people. Let's say they get in a pretty bad motor vehicle accident, and they're all banged up. And they come in and they're like, I was in an accident, and they get into the story, but it's not that bad. Like, don't say that. Don't say that to insurance. Don't say that to the police. Don't say that to the at fault party or whatever the case may be. Like, don't say it's not that bad. Because what happens is when you get hurt, the body is starting to modulate the pain. Now, at some point, the opioids that are built into your system are, they have a half-life, right? So they start to wear off. And when this happens, you are like, okay, that's what ends up happening. You are fine, and then you're not. And so if it's an insurance thing, for example, if you were hit and the other person is at fault, and you told everybody you're fine, and then once the opioids wear it off and now you're not fine, you're kind of screwed. Okay? Because they're like, well, you're changing your story, and it's been several days and something else could have happened after the accident that causes pain. Okay, so just for yourself, friends, family, and anyone else you can influence, if you now listen, I don't want anybody to get in an accident, but if it happens, just don't say things like I'm fine. Just wait. Okay, you're like, I don't know, I just give me time to process this. Okay. And then I promise you, once the opioids, the built in opioids wear off, things start to hurt. Okay. Now, medically, they can do things like morphine to block pain or modulate pain. I guess oxy is another one, right? Different things in the prescription opioid family. Okay, and then those drugs are engineered to try to get in to where the nerve that synapses on another nerve or tissue, the receptors are either blocked or the actual transmission is blocked. Okay, depends on the medication, depends on what the situation is. All right, any questions or anything at this point? All right. Okay, fibromyalgia. This one is wonderful. You've got all this chronic pain. We don't know what it is. We've run every test known to mankind and we found nothing. So you have fibromyalgia. Good luck to you. Okay. This one sucks because of that very reason. We don't really have any bona fide tests that quote unquote prove that this is what you have. So this is definitely chronic pain. Okay, now on the what I tend to agree with in the fibromyalgia world is this. In no particular order, number one, it's past trauma. Usually in youth, okay, usually in youth, and it usually has to do with some form of sexual abuse, verbal, and other forms of narcissistic abuse stuff when you are very young. Okay, now when you're young, you really don't have much control over things because you're 5 or you're 8. You know, you're little, and no one is really an advocate for you, so it sucks. All right. Now there's different types of trauma that we could put under here, but physical abuse and so on. But really, it's anything in that family that creates a deep emotional scar. And the idea is the cells have a memory, and there's some people that emotional scar goes deep into the cell, influencing it. Okay, other things that don't help. Lifestyle stuff, so smoking, drinking, drugs, poor diet, pro-inflammatory foods, excitotoxins, like for example, consuming too much MSG is an excitotoxin, and so on. Okay, so diet and lifestyle doesn't help. So if those things are kind of on the not so good list, it's going to take a pre-existing condition and make it worse. Okay, another one is stress. People with fibromyalgia notice increased pain when they have increased stress. Okay, another one would be infections. Okay, so the infections, if you have fibromyalgia and you get an infection, it makes your situation worse. Also, uh, infections is categorized, or not categorized, but put with another thing that happened in youth. So in other words, fibromyalgia could be set in motion by the abuse stuff in youth and or infections in youth. Okay. Again, rooting deep into the cell. And as time goes by, the cells have their physiological way that they try to handle these things, but unfortunately, it recruits the pain pathways. I work with a lot of fibromyalgia people. I have no magic wand. Nobody really does, but we do get it under control through um, alternative medical techniques such as stress management, improving sleep, certain forms of exercise, reducing anxiety, picking your battles, right? Like trying not to let certain things stress you out, getting rid of things that are creating the inflammation, pro-inflammatory foods and smoking and so on. Okay, we just go down the list of things that we can control. And you put it on the table with them through your motivational interviewing factors, and then let them see the pros and cons, and then let them make the decision for themselves. Okay. And usually what happens is, in my experience, especially if you're older, and by definition here, 40 something or older, if you've had this for 20 years, you're over it. And if it means waving pixie dust from Tinkerbell on your kneecaps, they'll do it if it means getting out of pain. So in other words, they're more open to doing some alternative medical approaches, such as stress management, dietary changes, and so forth. And when they start tapping into it, they actually start to see improvements. Again, it doesn't cure it, but it takes it from a 10 out of 10 all the stinking time and knocks it down to like a 2 out of 10. And they're happy with that. Okay. Okay. Migraines or headaches. Okay, is obviously a lot of pain that people can get. Okay, it can be acute or chronic. Okay, and there's different things that can cause it: tension, hormone or hormonal, dehydration, trauma, lack of sleep. Okay, stress. So what happens is, in the brain tends to get bombarded with an abnormal amount of what we call aberrant, nociceptive, sympathetic input. Okay, aberrant, nociceptive, sympathetic input. Okay, now if you think about these fancy words, abnormal pain because of stress over time. And all these things I just mentioned are stressful to the body. Okay, so headaches can be quite complicated because, there's a lot of stuff to deal with. So this is probably the number one thing I deal with in the kind of work that I do is headache stuff. And so we start with the the muscle tension, the poor posture, the poor ergonomics, right? So the nerves that come from your muscles and your joints and all that that go to the brain, they're being overworked, hyperactive, hypertonic, bombarding the brain with all this input that can cause pain. So we start nipping that in the butt. Dehydration, we talk about that. That's kind of easy to nip into the butt. Okay. We start putting stress management, which can help us sleep and other things on the table. It can be from caffeine, right? You can get caffeine induced headaches. So there's a lot of things that we start going down the list to try to nip in the butt one thing at a time to get these headaches under control. And if the person will go along for this ride, it is very effective. Okay, now some things are tricky, when you're dealing with malignancies, if you're dealing with, um, significant past traumas, epileptic people, stroke, fibromyalgia, okay, and so on. Those are a little bit harder to manage. But if you don't have those pre-existing things and it's more lifestyle stuff that we can get under control, the headaches start to go away. Okay. And then another thing that people like is, if they've been on certain, migraine medication for 30 years, they're kind of tired of taking it. They'd love to get off that stuff. Okay. However, you do have the option of taking your NSAIDs. Okay. And then if it's really bad, the opioids, oxycodones, and so on. Acetaminophen might be able to work. So that's your Tylenol and ibuprofen stuff. Tylenol is acetaminophen, but then they can trade with the NSAIDs such as ibuprofen. Okay. Sometimes they try to mess with serotonin levels. Okay, so serotonin receptor agonists to try to get certain headache things under control. So simply put, so they'll put medications as sometimes a go-to to help with that. All right. Any questions or anything at this point? Okay. So let's go ahead. All right. Let me screen share this with you. Okay, so psychotic illnesses. All right, so a lot of this, in a way, you can look at it as definitions, terms. Okay, understand the the condition itself, like schizophrenia, and what it is. Years ago, probably about 10 years ago, I just tried to co-manage certain mental illness cases with some medical practitioner friends of mine because there was some up and coming data that suggested that with the neuroplasticity of the brain and things like that, there's some changes that could be made. And so started to tap into, helping with some mental health. And long story short, it's tough. It's tough. Ended up maybe probably about 12 months of it. And then it was just very difficult. Okay. And so I realized that this is quite a specialty. If people are going to go into psych, that's really all you really have the bandwidth to focus on. And so on my end, trying to do musculoskeletal and all these other things on top of co-managing with some psych cases was just difficult. And I also realized that uh, you have to, you as a practitioner, you have to have the space and the time and the bandwidth in order to, really try to help these people and visit with them and do what you can to help, because it is tough. I'm telling you, mental health stuff, a lot of it is very tough. Um, Now, some of it, which we might talk about in a little bit, is I think a little bit easier to work with. Like, for example, everyday depression. Not really any psychological disorders or other, hardcore pre-existing conditions. Not really dealing with that. Just everyday depression stuff, like, it's my first breakup, or I lost my job, or I moved to a new area and I don't know anyone, or I had to put my dog down, stuff like that. Like that, those are sad events, and it is a season in that person's life that can cause depression. But I do think that that type of depression is easier to work with than schizophrenia, or bipolar, um, other major mental illnesses. And so, in other words, just some mental illness things are easier to work with than others, and some are very difficult. And these we'll talk about are they're just tough. So just keep that in the back of your mind if you're going to specialize in psych one day. It really takes a special person, and you also need to find ways of healthy escapes, because it's easy to kind of absorb people's negative energy, and I don't mean that in a foo-foo way. Um, some people are the life of a party. They're funny, and they just bring good energy. And I mean, like puppies, right? They come into a room, they just bring good energy with them. And then other people, boy, they can just suck the life right out of you. And so you have to be careful about that and find healthy escapes to recharge yourself. Because if you don't, then you will risk burnout, and you will risk just having some of your own um, mental problems, because you're taking on too many people that have some pretty serious mental illnesses, and the stuff that they will project onto you. And without having healthy escapes and ways to kind of recharge yourself, you'll actually start to um, gain some mental problems yourself. So just don't forget that part as well. So schizophrenia, um, their perception of reality is altered, and these are usually chronic and ongoing. They may have periods of, like a pause in the season, but then it comes back, so they can relapse. And it usually impairs their social function and their work function. So they just have a hard time kind of fitting into society, so to speak, or at work. And the word itself is broken down into how we would say it, into a split mind. So that's the word schizophrenia is translated into split mind. And, um, different ideas of how this comes about. Some of the psychology literature I've read, they don't completely fully understand it. There's, the genetic cause. There's perhaps some environmental cause. Some people even get into some spiritual things. Um, that might be some reasons, but uh, but it's tough. It's a tough one to deal with. Usually with schizophrenia, you do have some associated disorders, such as cardiovascular disease, and they do have an increased risk for type 2 diabetes. Sometimes the medication, the antipsychotic medications, can have certain side effects, so those need to be strictly monitored. Suicide is can happen with schizophrenia. Okay, other ideas are the overabundance of different chemicals or imbalances in chemicals in the body, such as dopamine. And it starts out fairly young, usually early to mid teens, can be some early onsets of diagnosis. They're also very convincing. I remember when I first started to work with some schizophrenia people, uh, tapping into natural ways of trying to alter the dopamine and the dopamine receptors and fix some other deficiencies that we believed might have been going on. Uh, Very convincing of the altered reality that they can put on the table. And now some of them are bizarre enough where you're like, okay, you just know it's not true. But some are so good of stories, they'll have you convinced, that these things happen to him or are happening. Like for example, I had one guy, and this is what threw me off. One of those guys I was working with. He brought in a gallon of water, and he was into working out, so he was kind of one of those that goes to the gym and carries the gallon water jug, as they walk around, kind of thing. And so that was kind of his thing was that gallon water jug, and he brought it in one day, and he puts it on the table, this big, and he goes, "I need you to test that." And I was like, "Okay, why? What's going on?" It's like, I swear someone poisoned it. After I put it down and walked away and came back and took a drink, the way I felt, and he just had this super convincing story of how he had just been poisoned and the way he felt. And I looked at him and I was like, okay, I mean, I can order, uh, we can take a sample of the water and have it tested, but it's going to cost you. And I showed him what the lab charges to test for different toxins and different drugs and different things that may have been put in your drink. I mean, there's a whole panel that they can do on that stuff. It was like $300, and he goes, "That's fine," and paid for it. And so that's what threw me off. Normally when you put money on the table and things cost, they're like, "Oh, never mind." But absolutely convinced. You know, so I was like, "Okay," and the test came back negative, and showed him, and he didn't believe it. Went ahead and proceeded with a police report. I mean, just went on and on about how he was convinced and had this game plan of how he was going to catch the person that tried to poison him. So anyway, this dance went on for, I don't know, like a month, and then I contacted the facility that we're co-managing with, because we're doing follow-ups and sharing information and um, different ways that we're managing clinically and all that. And so I put this on the table, and then they went, "Oh yeah, he tells that story all, all the time." Well, the heads up would have been nice, because sometimes schizophrenic stuff, they'll tell you things and you can pick up pretty quick. This is just their altered reality. But again, what threw me off is the willingness to pay for these tests. I'm like, well, if someone really believes that this happened and it's not an altered reality, then they'll pay for the service, right? So anyway, that's what threw me off. But you learn. So you start getting around people that convince you of an altered reality, and other things that can get really subtle, such as patients that know how to gaslight you. Um, Maybe they're a narcissist in the way that they know how to take control of situations. So it's easy to be manipulated with certain psychological disorders. You just have to be aware and alert. There's usually a learning curve at first, but once you can see through the stuff, then it's harder to pull the wool over your eyes as you gain experience with dealing with mental health disorders. Okay, sometimes they will have hallucinations, and again, some of them are very off the wall. Once they start talking about aliens and how they come in, with certain uh, contraptions that can warp you into another dimension, like those, you're like, okay, you just listen to them and you work with them, and that one's really not going to get you because it's not real. But sometimes they come up with stuff that's absolutely convincing. Okay, sometimes the thought process is disorganized, and you'll kind of catch them in change in stories that's not quite consistent with which what you would think it would be. Like I had another person claim that they had started a business and made hundreds and hundreds of thousands of dollars, and it was stolen from them. And homelessness and living out of their car, and someone stole their car, and all these different things that they put on the table. But then as time went by, the story kept changing, and it wasn't very consistent um, with their disorganized thinking. Okay, so sometimes you'll pick up on that. The behavior will be quite disorganized, anywhere from temper tantrums, childlike behavior, agitated very easy, to like almost a more stern, rigid approach to you. Their bodies can even go into canatotic motor behaviors and create rigid postures. um, so the with the dopamine receptor activity, there are when you're dealing with a deficit like that, and you get certain loss of dopamine uh, functions, and one of the things about dopamine, it's a reward center in the brain. Okay, and boy, we could talk about that for 100 weeks. Um, the most people these days falling prey to the dopamine reward centers, and you can blame that on social media and other things. Now that's becoming well documented, so that's I'm not making that up. But maybe that's another discussion for another time. But the dopamine specific neurons in the brain, um, which are part of they have an association with the limbic system, okay, which is kind of the mood system, the social behavior part of the brain. And um, so in a normal functioning limbic system, we have behavior control centers, right? The amygdala is part of that. And the neurotransmission with schizophrenic is kind of rerouted, so to speak. It's off. It's not quite firing right. So the dopamine D1s and the D2 receptors that are deficient in some glutamate transmissions, uh, are usually present. So these are when you hear chemical imbalance, these are some of the things that they mean by that. And so they sometimes the medications is a little bit of trial and error. If you think it's a neurotransmitter problem, you can do that. If you think it's a receptor problem, they'll go down that path. If it's a deficiency problem, then they'll go down that route. Like like GABAs, for example, the GABA interneurons. Um, anyway, so these take it's a highly specialized position to be able to diagnose and give the appropriate meds. But some, the nurses that are kind of the front lines people that have to do this in the psych areas of the hospital, you have to watch out for the attacks, the language, a lot of inappropriate behavior. You know, um, sometimes things can get pretty rough and physical. So anyway, if you go down that psych route, especially with training from the hospital, usually what they'll do is once they hire you and you want to specialize in something like cardio ICU or NICU or psych, they usually go through training and they teach you this stuff, what to watch out for, um, and so forth. Okay. Okay. So the some of the things that help with diagnosis. So delusions, hallucinations, the disorganized speech, abnormal psychomotor behavior. Okay, the genetic side of things, it does. There's a graph here that will show you some correlations with developmental factors, prenatal infections, malnutrition, birth complications, brain injury that have associated. Some of this gets into epigenetic studies, and what that means is you create new receptors, a new type of protein receptor with certain environmental influences that come in that can increase the risk factor for schizophrenia. Okay. So there's some of the medications that would block the D1. Um, and, so the idea is to calm down the area to deal with the antipsychotic version of medication. So non-pharmacological, uh, that's what I was trying to do with certain, things that deal with nutrition and brain nutrition specifically to get these deficiencies back up. There's also a correlation with the gut-brain axiom. So the more off the gut microbiome is, the more it's going to throw the chemistry off. And if your gut doesn't have enough components to make certain things like serotonin, then that will throw off the behavior of the person. So at the time, that's the arrow I was trying to go down, but it was too much because of the weight that is put on your shoulders from the way that people visit with you, with the stuff we just mentioned before. And it wasn't just schizophrenic people; it was also bipolar and some other like ADD, ADHD. Some of that was in there as well. So cognitive behavioral therapy and other forms of like mental rehab, um, working with people on social skills, and also how to improve their skills at work, and then how the family can get involved to help. So I think those are great. The word counseling can be off-putting to people. So I learned years ago to change it to a life coach. I know that's, today that is a term that wasn't really that popular of a term back then, but today you're seeing more of that. Uh, and it works. Like, here's an example. If you went up to someone and they said, "So how's it been going?" And you go, "Well, I've been going to counseling, or I've been going to see a shrink, or I've been going to mental therapy." I mean, those are kind of buzzwords and people are like, okay. All right. So, and then maybe you'll tell your story, but they're still kind of like, okay, different day, same person. They come up, "Hey, how's it been?" "Oh man, I'm having a great, it's just been great." "Oh, what's been great?" "Well, I've got this life coach." "A life coach? What's a life coach?" "Well, they just help you kind of navigate through life, and if you talk about it that way, it's like less of a buzzword, and then people are like more open to it. Okay. And so, even though at the end of the day it is counseling, instead of saying that word, you might just change it to a life coach. You're having coaching through certain seasons, or you're navigating through certain times. Like, for example, if you're going through depression, and let's say it's your first breakup and you're just stuck, right? You don't have any motivation to do anything. You don't want to get out of bed. You don't want to go to work. You don't want to study. You don't want to do anything, right? You're stuck. Well, in the long run, that's not a good place to be. It's just constantly stuck and living in the past. So you might need somebody to help you navigate through this territory. And so that would be a coach. And you would say, well, they're just helping me they're coaching me through this difficult time. And then you can, if you want, you get into your story, and it's more receptive to people, and they actually think it's kind of cool. And then it turns into like, wow, you're awesome. Like, that's so brave of you and mature and all that for you to do that. That's great. And then especially if you have a healthy outcome, they're like, man, everybody should go through this, which I think is okay. It's okay to learn, uh, for families to be counseled and for people to be counseled or coached on how to work with a family member that might have some sort of mental illness, or if you yourself are dealing with some sort of mental illness. I think it's okay um, to have coaching to go through that. So major depressive disorder, that's actually been revised over the years, and um, usually this is chronic and ongoing, so it's persistent, and it does encompass a bunch of different types of depression that they pulled together into the major depressive disorder category. Okay, so um, it does require the presence of multiple symptoms intense enough to cause distress and impair psychological function. Okay, this can also develop serious secondary illness or complications. It's kind of no secret that the longer a person lives in a depressed mode and other mental illness modes, it takes your health and goes south. Okay, we could talk about the gut brain axiom because of that. You can talk about the different stress that comes with the package, and how the adverse effects of stress, and um, on and on it goes, right? So then it leads to more deficiencies, and the brain just starts to fall apart. Okay, so these things do tend to get worse over time. Um, so when you're visiting with someone that's going to help you diagnose, there's several things that they look for, and you can see a list of that there. Okay, so number one, felt sad, down, or miserable most of the time, lost interest or pleasure in most of the usual activities, lost or gained weight, or increase in appetite, sleep disturbances, felt slowed down, okay, felt tired, felt worthless, um, poor concentration. Okay, I think a while back I mentioned to all that when we do our functional medicine protocols, they fill out a 152 questionnaire as part of that. And some of these are actually in there. Okay, so those questionnaires were actually strategically designed to look at the different systems in your body. So it looks at mental health, it looks at GI health and cardiovascular health, and so on. All the different systems, and then you run that questionnaire through a computer algorithm program, and then it gives you all these different patterns and correlations of what you're likely dealing with from the most severe to the least severe. Okay. And so this is actually part of that. And, if I pick up on that, reoccurrent thoughts of death, so suicide tendencies, the poor concentration and so forth, then, I'm, we talk about it best we can. And I have several counselor type people that I can refer them to. And that's really all I can do is, you put the ball in their court, encourage them and empower them to dive in a little bit deeper with this. And some people do, and some people don't. Um, Also, we're seeing this in younger and younger people. I'm in the Cherry Creek School District area, and so I see a lot of Cherry Creek High School students and athletes, and some Arapahoe High School, and some Heritage, and also some Regis. And so, being in sports medicine, I take care of a lot of athletes. But with these teens coming in, they start putting things on the table that they wouldn't normally tell their parents. And, you just realize that youth depression and all that it's higher than you think, so, um, and that's also a tough one to pick up on because, they really don't want to really say anything. So anyway, as a future provider, if you're picking up on signs and symptoms of anything that you feel might be a red flag, then it's worth saying something, okay, without violating HIPAA stuff. But if you can, you want to say something. So these questions, feeling guilty about things, and difficulty thinking and so forth, are part of the questionnaires that we will do as well. Okay, now I don't diagnose them. I just make the correlations, and then because that's out of my scope to diagnose something like that, but we can at least pick up on it, and then um, refer to the appropriate help as soon as you can. Okay, some clinical manifestations: depressed mood, the loss of interest, the all they want to do is sleep. All they want to do is stay awake. Everyone's different. And me personally, if I'm sad or any, stress, things in that family, I can't eat and I can't sleep. That's just how I'm wired. But other people, all they can want to do is eat and sleep. Okay, so with the major depressive, the cause still remains unknown. There is some growing data in today's culture, at least, about the views of self and life. There is some very strong literature out there that talks about, that has correlations with social media, comparing Instagram likes with each other. Everyone's story on Facebook is better than mine. People are bullied through social media. In fact, there's a lawsuit going on in Arapahoe County right now about that, where some high school students encouraged through social media of someone to commit suicide, and that kid did. Okay. And so there is a lawsuit going on with that. And that's kind of new territory, right? So in the legal system, I mean, if you think about it, how many cases that really go to court? Uh, so what do you do? So I think that's, as far as the legal system is concerned, is going to step in and actually figure this out, because it is a growing concern and it is a problem. Um, so anyway, that happened in Arapahoe County, and that was fairly recent. So the views on self and life, there's a variety of factors. Today, the common one seems to be because of social media, and uh, uh, also, as far as pharmacology stuff is concerned, if I read what I read correctly, at this point, the number one prescribed medication in 2020 is antidepressants. Okay, part of that might be because of zombie apocalypse and riots and elections and COVID and people losing their job and businesses. All travel's gone. Like pretty much everything was taken away. So sure, I can see how that would depress people. If you already have a pre-existing condition, it would take a bad situation worse. So what I read was the prescriptions for antidepressants has gone up quite a bit, and it's now, as of 2020, the number one prescribed medication. Okay. So common one is selective serotonin reuptake inhibitors, or SSRIs. They're trying to, through medication, tap into balancing the serotonin. Uh, on the functional medicine side, they say it works at first, the medication works at first, but as time goes by, the brain kind of figures out, oh, okay, I see what you're trying to do here, trying to trick us through some medication, so it can change, and so then the medication doesn't work anymore. And usually the person will express that to the prescribing doc, and so they'll either up the dose or change brands or change prescriptions, right? So it does work at first, but then in the long run, it may not. So, from functional medicine, what we are taught and try to work with our patients on is, if you need the SSRIs and antidepressants and stuff at first, that's great, because it can help. But simultaneously, you want to try to do the other things as well, like the counseling stuff, a support group, family, being on the same page to help you. If you're finding things in their diet and lifestyle that is hurting them, try to alter that, and then teach them the skills to navigate through this difficult time and develop the skills. Okay, and that's another thing that they've noticed, is a lot of people don't have the skills to navigate through certain down times or depressing times. And it's teaching people to develop those skills to navigate through it. Okay. And then as time goes by, hopefully you'll see improvements, and then you can wean them off the medications. Um, Otherwise, some of the side effects are altered mental status, and they can get agitated. They tend to be more anxious. They can sweat. It can create headaches, gastrointestinal disturbances, changes in appetite, changes in sleep wake patterns, and so on. So there can be some side effects to the SSRIs. Okay. Um, Always, you can put in, with any kind of mental disorder, some form of cognitive behavioral therapy, life coaching. Okay. There's a there's also some new research coming out on how to alter your own sympathetic state of mind. Absolutely fascinating stuff that's coming out of Stanford and some other places. One of the leaders in that is a guy named Dr. Andrew Uberman, with an Huberman, Uberman. He's a neuroscientist. And when you read his work and the stuff that they're doing and other people like him are doing, it is fascinating, the stuff that they're figuring out about what you can do to alter the brain and move it in a healthier direction. Okay. And so, anyway, these days, wonderful stuff is coming out, from breathing techniques to certain exercise techniques, kind of in simple terms, mind over matter techniques. I mean, I know that sounds cliche, but when you look at the science of what they're doing, this isn't just, oh, go out there and breathe. This is, here's the specific breathing pattern, because we're trying to tap into certain parts of the brain on purpose to override the sympathetic parts, to change some of the chemistry, right? So they get real specific with what's going on. And then they take all these people and they study them and they research them and they scan them and they do the functional MRI scans, and they measure their blood. They're looking for the different hormone levels as things change, and on it goes. They look for pupil dilation as they're going through different cognitive behavioral therapy techniques and so forth. And it's just wonderful, the science that's coming out behind different techniques to help people through different counseling and other behavioral therapies. So if you ever get a chance, Andrew Huberman, he and his team try to release once a week on their social media, YouTube and Instagram and all that, just updates and different things that they're working on. And the cool thing about Andrew Uberman is he also correlates it with animal behavior. So he goes, here's what we see in animals. Here's what we know through their neurology and stuff we've extracted and tested and all that kind of stuff. And look what we're finding in humans, and look at the behavioral, similarities, right? Like for example, they'll take a rat and they'll isolate the rat from birth, um, and then they take the rat when it's older, like the rat's version of an adolescent year, and put it into the rest of the pack to see what happens. And you should see the stuff that happens to the rat that was put in isolation and then reintroduced into society. Okay. And because it's a rat, they can then euthanize it and extract the brain tissue and then compare it to a healthy rat that's been socialized and all the other stuff that you would expect. And they get real detailed with the different things that they're finding in neuroplasticity. You can't really do that in a human, right? Just take a human out there, isolate them from birth, and when they're teens, put them in culture and then euthanize them and take brain tissue. Like you can't do that with humans. But with certain science experiment things, you can do that with mice and rats. And so there's just some things out there that are showing you animal behavior, both what they're doing in the lab and what they just watch in nature. And then they do the same with humans and they make these correlations. And you're like, it's like jaw dropping stuff. Okay. What they're figuring out. And I think all that is great because it just leads to better understanding of the brain, better understanding of mental disorders and depression, schizophrenia, and so forth. Okay. And I also think we're just scratching the surface. And as time goes by, that stuff is going to get better. With bipolar, um, so kind of fun, opposite ends of the spectrum things that happen uh, with bipolar um, people. So depression, that can be pretty severe to create different psychosis, and then followed with there can be some mania that comes with it, which is a hallmark of um, bipolar disorder. And then bouts of they're fine, and then they're not, and then they're fine. um, so these days they do have bipolar 1 and bipolar 2. So bipolar 1 requires past or present history of full manic episodes, and whereas bipolar 2 is past or present of hypomania, so they never fully manifested full mania stuff. Okay, so as time goes by, they get more specialized and more detailed with what they're finding with bipolar, and um, the risk factors are um, kind of the usual suspects. There's some genetic correlations, and then some environmental, some epigenetic with changes in protein receptors and other receptors in the body. Okay, so yeah, here's some fun things I know: how to win the lottery. Women are crazy about me. I don't need sleep. I can do anything. I have the answer. That will bring world peace. Um, so in the psychology world, these cartoons that they can send to each other, that's another one. You want to look at some of the, you know, psychology clinical cartoons they send to each other. It's kind of like the attorneys, the same attorney jokes they send. They can be quite uh, to some people they're funny, to others they might be offensive. But um, let's see. So other clinical manifestations with bipolar would be the decreased need for sleep. Okay, fighting off ideas or subjective experiences, um, easily distracted, and excessive involvement in pleasurable activities that involve a high potential for painful long-term consequences. Okay, so pharmacological treatments, back to medications, depending on what they believe will help at the time. So lithium is one of them. Now I'm able to prescribe a very low dose of lithium, and so we do try to incorporate that into some people's routine. It's certainly not prescription strength, but it's enough to perhaps get uh, the mood and things to stabilize. Okay, again, back to cognitive behavioral therapy. And these are very common with any kind of, mental health. You're going to always have the medical, medication, pharmacological approach, and then your cognitive behavioral therapy approach, and then other forms of functional medicine approach. That would be the same for ADD, ADHD, post-traumatic stress, and so on. Okay, there can be some hormonal influences for different mental illnesses. Um, so serotonin is one of them. Changes in estrogen, progesterone, changes in oxytocin. Okay, hypothalamus pituitary dysfunction would not help any for your, anything that has to do with mental health. Those are easily tested through labs. Those are some areas on some cases that I still co-manage with. I'll put those on the table to look for different hormone imbalances. And then sometimes when you get those hormone balances more stable, then it's easier to work um, with people. Okay, let me get 49, chapter 49. Okay, so anxiety or anxiety disorders. Okay, so panic disorder. So there's four different ones: panic disorder, generalized anxiety disorder or GAD, obsessive compulsive disorder (OCD), and post-traumatic stress disorder or PTSD. Um, so panic disorder is acute episodes of anxiety symptoms, unexpected, sudden, intense feelings of fear. Okay, sometimes they'll have increased heart rate, chest pain, dizziness, numbness. Um, I have a um, pretty long fuse when it comes to working with people like this, which means it's hard to get to me. But every once in a while, someone will come in and um, just the way they present themselves with some of these physical symptoms and the tremendous amount of stress and panic that's going on, it can get thick, and sometimes, uh, you just have to say, look, I can't help you here. You've got too much going on. Here's some people that are really good at this stuff. And I mean, even that alone starts to create more hyperventilation sometimes in people and break out into a sweat, just really tapping into the sympathetics. Um, they'll express fear of dying, um, and uh, sometimes they exaggerate their situations. and the way that they talk to you, because sometimes what they're looking for is some sort of sympathy response. Okay. And certain forms of counseling will help. And, the life coaching, the cognitive behavioral therapy, the benzodiazepines are commonly prescribed. And but once you get into those, you also have to be careful if they're going to try to wean themselves off, like weaning off of that stuff. Very, very careful once you get on the benzos. Okay, so anyway, just recommend to your people, like, don't just take yourself off of that. Like, you're going to need some help. Um, so generalized anxiety disorder is just worrying all the time. Okay, and the worry, you're tapping into sympathetic, so your body's constantly releasing those particular neurotransmitters. And then as time goes by, restlessness, fatigue, impaired concentration, you're more irritable, uh, muscle tension. Boy, this one, I tell you, when you do musculoskeletal with people and you palpate, thousands and thousands and thousands of muscles over the years, you can tell when anxiety is in a person, when stress is in a person. And, again, they're not in there for someone like my clinic, they're not in there for that, but they may have it. They're just not really talking about it. They're in there for their headaches or whatever. But there's sometimes you can just palpate a muscle and you can tell this goes beyond just a tight muscle because of working out or overworking out. And then you may, as you're palpating, you may say something like, what is going on? And they know what you mean by that. And sometimes they'll just melt into the table and they start crying. And, and people will usually say, I'm sorry, I don't mean to do that. It's like, no, it's fine. It's just your body's way of purging, of getting rid of things. I think it's good to allow the emotions to come out. It needs to be a safe place for that to happen. I think a lot of people don't feel safe in certain circumstances, so that's why they just hold it in. But once people feel that they're in a safe place, and sometimes you can remind them, like, this is a safe place to do that. It's okay, just let it out, and they will. It comes out, and then the fog clears a little bit, and it can help, right? So to start to unwind this tension and unwind the stress and the anxiety that's going on. So because it is anxiety and because you are likely in chronic sympathetics, the symptoms will vary, okay, from the muscle tension to the headaches, stomach distress. Remember, your body does not like to digest food well in sympathetics. It can mess with your sleep. You can be fatigued. Lack of sleep does change the chemistry in the brain. People tend to resort to what's called the lizard brain when it comes to lack of sleep, and they start to make decisions that aren't very wise. So, when you mess with sleep, especially over a long period of time, that alone can create more anxiety and problems. So the etiology, neurobiology, gradual onset. Uh, so the twin and family studies have a documented a 30% increased risk among relatives of a person with the disorder. So genetic component there. Anxiety symptoms are a manifestation of hyperactive brain circuits, and brain regions undergo both increase and decrease in glucose metabolism rates. Also, your altered norepinephrine serotonin activity. Do you want to screen for alcohol abuse? And, the prescribing doc will, they have a list of things to choose from, right? Your benzos, your SSRIs, other antidepressants, beta blockers. Cognitive behavioral therapy tends to do pretty well with people with anxiety. Okay, obsessive compulsive disorder, persistent involuntary thoughts that provoke anxiety. Okay, commonly, referred to as OCD. And there's different obsessions, excessive washing of hands, excessive cleanliness in the house or wherever in the place of business. Um, everybody has kind of their own thing of which they're OCD about. Uh, okay, so usual suspects of genetic or inherited risk for developing OCD. Increased glucose metabolism rates are found with brain scans. So diet can help that. You're trying to one of the things when you look at it from a diet is what do you crave? What are they craving? And usually, um, now they don't realize this, but what they're craving is sugar, okay, carbohydrate stuff, glucose stuff, high glycemic index food stuff. So you have to really coach them through to start watching that. There are some up and coming studies. It's very infant and kind of brand new with ketogenic diets and brain health. Some really cool things out there that they're starting to tap into. One of them is OCD, other uh, mental behavioral issues, and the ketogenic diet. They're also evaluating stress. Like an example, they're taking certain military people and special forces that are exposed to extreme events, like Navy SEALs, for example. They're put in cold water, they're deprived of sleep, they're starved, excessive exercise, and on it goes. So they're really breaking the body down. And so now they're doing some of these comparative studies. They're taking groups like that and putting them on a keto diet and having them go through those type of activities, extreme activities, um, flirting with hypothermia, sleep deprivation, and so forth. And then another group over there, just kind of their regular non-keto diet, and they're going through the exact same thing to measure the outcomes. And so far, some of the preliminary results, they're getting much more favorable results with the ketogenic diet people. Okay, post-traumatic stress. Um, so these are usually caused by some sort of traumatic event that can cause anxiety, and depression. Um, so the flashbacks that they can have can make symptoms worse over time because they keep reliving the events. I do work and deal with some veterans, from Vietnam to Desert Storm, and so on, Afghanistan, and um, so I have some connections with the VA hospital, and so I've got some people that are coming over. Now I don't see them for behavior reasons. I'm seeing them for musculoskeletal things, but they also put that on the table. They're coming in with their busted up neck or their sciatica or whatever it is, and but because they have other conditions such as PTSD because of combat in their case, eventually they put it on the table. Like some of them will actually talk about it with me. And then because of how many veterans I've treated over time, it's they're some of them that have gone through the behavioral therapy things and some medications and have talked about it, like they tend to do much better. And then some of them also have spouses, so eventually the wives come in And, um, and some of them been married, for 30 years, right? Long time. And so they've got these wonderful stories to tell you how it used to be and how it is now. Just the different transformations that some of these soldiers have gone through over time because of things that they've seen and the stuff that they've experienced. Okay. And it is very sad. Um, but I also think that hopefully the old days of, oh, just suck it up and toughen up and, move on with your life, those are over. And the days of putting it on the table and going through different therapies to help navigate through the stress, the post-traumatic stress, can help. Okay, there's some back to that neuroscientist I was telling you about earlier, Andrew Uberman. He'll talk about some of the light therapy, some of the strobes and different things that they're doing with eye movements and different light therapy that can help. And there's some other really cool like neuro counseling techniques that they're finding that are helping tremendously. And once, and then the other thing that they will do that helps is they'll find kind of their thing, their hobby, something that makes them happy, whether it's golf. Like I had one Afghanistan veteran, he was actually at the 101st Airborne. He told me all the different, paratrooper jump things he did out of an airplane with a parachute, and just got into a bunch of different things that he saw on what he said his 35th jump. Landed funny and busted up his knees and his back, and so in sports terms, that put him on the disabled list. So he couldn't really fulfill his military duties anymore. But he dealt with a lot of post-traumatic stress, and so that's why he was in, because of the musculoskeletal problems from landing funny from parachuting. But ended up, um, as I was taking care of him, and then he was going through counseling stuff at the same time, he also found his hobby, and it was um, searching for rocks, like going out and trying to find Amazonite and, the different rocks and minerals that you can dig for, and ended up bringing me some things. So if you were to come into my office right now, I've got a special glass case that I bought because of all the different rocks and gems and stuff that he mined, like dug up. And it was very therapeutic. And a lot of places, if you do that, you cannot do blasting. It's very difficult to chop through rocks and stuff and to dig. So you can pay a fee to enter into the park, and it's sometimes hundreds and thousands of acres that you have to choose from. You just wander out, kind of do your thing, and you can dig and look for rocks and gems and so forth. And so that was his thing. So he would bring me stuff, and then on one of his visits, I said, "Look what I got," and he looked, and he was just so thrilled that I went out of my way to get a special glass case, like a display case, to put some of the rocks and minerals that he brought in as a thank you for helping him navigate through some of these things together. So all I did was get his muscular stuff, skeletal things better, and listen to the things that he had to put on the table that dealt with post-traumatic stress. Okay, I didn't intervene. I didn't give him any mental counseling advice stuff. I just listened. And sometimes just listening is very therapeutic for people. Okay, and he was going through some other medical and other psychological counseling things on the side as well, and all together it really helped. Okay, and he's in a much better place now in his life. So those rocks, I'll keep them forever. They mean a lot to me. I show just about everybody that comes in. One of them is lead in the raw. Most people have never seen lead in the raw. And I've got this little rock that's got lead that's still embedded within it. And it's really cool. some of the stuff that he brought in that he found on his own. Okay, the limbic system, which is the emotional center in the brain, part of that is the amygdala and the cingulate gyrus, tends to be hyperactive. Okay, so SSRIs are the first line of treatment to see if they get some improvement. In my personal bias opinion, I think that the medication plus cognitive behavioral therapy stuff should be done at the same time. Okay, I think it's more powerful if you can get both. And then if you can throw in a third one with family support and also some diet and lifestyle changes, I think that helps even more. But at the very least, cognitive behavioral therapy and some meds. And you'll also be surprised at how many people are resistant to getting cognitive behavioral therapy or coaching help. No, I'm fine. I'll just figure it out on my own. I got this. It's like, no, you don't. It's been 30 years. You don't got this. Don't say it that way because that's not part of motivational interviewing. um, okay, so neurodevelopment disorders. Okay, this can, a guy named Bruce Lipton, Dr. Bruce Lipton, PhD out of Stanford. Um, he's really big on neurodevelopment disorders through epigenetics. So his personal research bias on this is the changes in epigenetic and protein receptors and rearrangement of this in utero. He claims it starts in utero. The stress that mom goes through and all that stuff, how it influences the growing and developing baby. And once they come out, they're now behind the curve with neurologically because of what happened during embryological development. And then you're subject to the environment, okay, socioeconomic status, and on it goes. Okay. And that right there can lead to behavioral disorders, depression, neurological, we'll just say underdevelopment problems as well. So you'll see problems with language and speech, motor skills, behavior, memory, different learning disabilities. This can also happen from trauma. So the pregnancy, for all intensive purposes, was fine. The mother was about as healthy as they come, a healthy family environment, everything was great, but just some sort of trauma happened, and that can actually start to spin things in a neuro underdevelopment direction. Okay, ADHD, attention deficit hyperactivity disorder. I've got a really cool story to tell you about this that actually involved going to court. So I was working with a child on ADHD, and we were doing different thalamic relay exercises and different, brain exercises. Also did a bunch of testing to look for what was provoking the ADHD, and we found it. And here's how it went to court. If you're like, what the heck are you talking about? Well, here's what happened. It's actually a really cool story. So the child came from a split home, okay, a divorced home, and the mother found out about me, started bringing in her child. And we did some awesome tests and labs and really, really cool things. And we found a lot of additional problems that were provoking his pre-existing condition, and the kid got better. But what happened was on the weekends when the dad would get him, the dad was not into this at all. Okay, he thought it was a bunch of crap, didn't believe that ADHD even was a thing, and all these, techniques that counselors and doctors and whoever are trying to help, it's all bogus. Okay, those are the two positions. The mom was into it, the dad was not. And what was happening was when the school would get the child on a Monday, the kid was a mess, like an absolute mess. And it took a couple days to kind of reset the nervous system because the mom would get him on Monday, but the damage had already been set in motion, Friday night, Saturday, and Sunday, right? And The work that I did for the child was for some research from a guy named Dr. David Perlmutter. Okay, he's got some really good cognitive behavioral things out there for kids. He's a pediatric neurologist. Okay, wonderful research on let's just say mental health, cognitive development, and all that kind of stuff with kids, with peds, right? So wonderful work. So used some of his work and incorporated it, and it was working wonderful. So the dad would get the kid, and I'm not picking on moms or dads. This is just the nature of the situation, right? Um, because sometimes the dad is the one that um, is trying to do everything right with diet and exercise and lifestyle and balance, and sometimes the mom isn't, and sometimes it's the mom that's doing that and the dad isn't. So it just depends on the household. Okay, maybe both parents are not doing anything. So it's obviously extremely variable. So I'm not picking on anything. That was just the nature of this situation. The mom was into it. The biological dad was not, and well, because they got remarried. So once we got to court, we had to kind of say it that way. Whether it's the step parent or the biological parent. Anyway, so the school would get the kid on a Monday, and it was just a mess, an absolute mess. But by Wednesday, it was fine. And this happened every single week for weeks and weeks and weeks. And the school's like, what the heck is going on? Why on Monday, Tuesday, and kind of Wednesday is this kid an absolute mess? And then Wednesday, Thursday, Friday, he's fine. Okay. Well, long story short, they got a guidance counselor involved, which turned into a social worker that got involved. And I ended up getting a phone call, and the social worker wanted to come to my office, and we talked. And I put everything on the table of what we're doing. And the social worker looked at me and went, "That's it? This is all the kid has to do in order to remain as healthy as possible." I was like, "Yes, this is it." And so, anyway, it ended up going to court. And what we're ultimately hoping for was the judge to rule in favor of the child, to make the dad follow the protocol that I recommended, that the pediatrician recommended. Here's another one: the kid even needed eyeglasses, corrective lenses. The dad wouldn't even do that, thought it was a bunch of crap. So the eye doctor was there. Like, all these practitioners were there on behalf of the kid. Okay. And the judge is kind of looking down and going, if you could, now the judge was professional about it, but if you could kind of um, really get into his mind and say what he was probably thinking, it was like, dude, seriously, come on, just follow the protocol. Are you kidding me? He needs glasses, let him wear it. If those things are provoking his brain, stay away from it. Okay, now the judge didn't say it that way, but you can kind of tell that's what he was thinking. Okay, because the protocol was too simple to follow. All right. So that's how it ended up going to court. You're considered an expert witness in a case like that. And there was a lot of people there on behalf of the child, and overwhelmingly it worked in favor for the child. So that was a good thing. So yes, there are things that can provoke, take a bad situation worse. So if you're doing things that are pro-inflammatory to the brain on top of deficiencies, okay, you can get the behavioral manifests itself in a worse direction. So that is a thing. So this statement here, there's no cure. So that wasn't the claim that we cured the ADHD, but what we did is we were able to take it from a 10 out of 10 and knock it down to like a 1, 2, or 3 out of 10. And everybody was happy with a 1, 2, or 3 out of 10. Okay, so the inability to focus, easily distracted, with the hyperactivity. So you're always wanting to move, fidget, you're always on the go. Reducing symptoms will help and improve the impulsivity, the hyperactivity. There's some medications that can be given. Behavioral skills and other counseling stuff can be done. Okay, and by the way, that kid I was telling you about was getting it all. He was getting like everything. Okay, and it was working wonderfully. Autism. Uh, so this is a tough one um, because sometimes it goes undiagnosed and for a long time, and then finds like, oh, you might have autism. It's like, well, why didn't you tell me that like 30 years ago, right? So anyway, so social communication deficits, and they typically have fixated interests and repetitive behaviors. Um, Changes in social communication, so they don't really want to make eye contact. They don't really want to interact very much with people. They're kind of uncomfortable in group settings, very introverted. And but also some of them can be very smart. So they call that high spectrum, right? Where you have your kind of off social behaviors, but yet at the same time you're extremely intelligent. Okay, so there's different levels of this stuff. Um, they don't really know what causes it. There are some ideas on the functional medicine side. We do claim it is neurotoxins, okay, things that have crossed the blood-brain barrier to hurt the brain are some reasons for autism. And um, so, medications can help, and going back to, behavioral interventions can help as well. Uh, So the building that I'm in, I've got two different office locations, one in Denver Tech Center and one in the Highlands area. The building that I'm at in the Highlands area is like a 6-story building, lots of offices in it, and there's like 15 different counselors in there in that whole building, and some of them specialize with autism. And because we're our suite mates and office mates, and we're in the same building, you kind of get to know each other and visit from time to time and go into each other's offices. And this chart I've seen in those offices. Okay, they've got some other cool charts and some things that they do, and toys and stuff that they use on purpose to help diagnose things with behavior with these kids. But some of them specialize with counseling kids. Okay. And then, of course, because I'm there with them, meaning in the same building, I'll pick their brain sometimes and we'll talk about things. And the key is if the child can stay consistent, and that's the key, is consistent with the um, behavioral approach, the therapies, the nutrition, the routines, they tend to do very well. Okay, and consistency. And that the reason why I emphasize that is because in our culture, we all want a quick fix. Okay, we kind of want the magic pill, the magic wand. I just want to go in once and everything is gone and done. Like it doesn't really work that way, especially when you're dealing with mental disorders. Like it's a process. Okay, and when you expand the opportunities for people to have access to this stuff, you do get you can and will get changes over time. Okay, and I'm going to put something on the table, and I don't want to really get into it because it's a nightmare of a discussion to talk about, and that's insurance. I do wish insurance would do better at covering this stuff. It can be expensive to do behavioral therapies and visit with life coaches and counselors, and change diet plans and all that kind of stuff. Like it is. I'll just be upfront. It's very expensive. But the work is very good. And I just wish that insurance would do better at helping people with that. Okay, any questions with any of the stuff that we've covered on this or today? Okay, next week is week 10. We are in the home stretch. We are in the bottom of the 8th inning. Okay, game's almost over. And so just hang in there. I know everyone's probably experiencing a tremendous amount of fatigue and burnout, right? So, uh, okay, so just hang in there. We're almost done. Okay,
I just had a quick question.
sure.
The homework that was due this week, is that going to be for a grade or is that just to do it? Because
What do
it's,
you all want on that one? Because I'm posting it either way, so because it's also a study guide. But what would you all want for that?
I mean, I would like to turn it in for a grade just to get
Okay,
some extra points.
okay.
Um,
So we have, uh, so you put it on the table. We had Jenny second it, and then all in favor say aye. Aye. Okay, good.
I
Done. All right, we'll do it for a grade.
okay, and then when is that going to be due? Can you give us
Um,
like, the end of the week, maybe?
oh well, sure. Yeah, you'll have. In fact, at this point, we'll just have everything due finals week to give you some
Okay.
time. So here's kind of the fun thing that happens, right? So you start a quarter or a semester at week 1 and 2. Everybody's fresh, right? You have the bandwidth. You're kind of excited, and then by midterms, people are pissed and fried, and then by the end of the semester, you're just out of gas, and it's the stress and whatever. Um, so, um, in other words, why have something due like tomorrow? So yeah, we'll give it to the end of the quarter to get it done, make it easier, less stressful.
Okay, thank you.
You're welcome. Hey, how'd you do on the quiz this morning? I think overall people have been doing well on those, which I think has been helping with some of the points or the overall grade.
Yeah, is there any way for that too that you can maybe set it so that we can see what we got wrong on it? Just, I mean, I don't know about everyone else, but I just learned better that way. So I can see like what I got wrong and learn from it that way.
Yeah, I think there is a way to do that. Um, Let me see. Let me take a look real quick. Okay. Yeah. Yeah. I think there is a way to show you the.
Yeah, I mean, you don't have to do it right now, just for us
Well,
to look at before the exam or something.
okay. Well, take a look right now. See if it's. I don't. Let me go to the quiz you took today. See if it's accessible.
Okay.